Good morning, colleagues and guests, and of course, our distinguished panelists. My name is Marjorie Gondre-Lewis, and I am a principal investigator alongside my colleagues, Doctors Joseph Verbalis at Georgetown and Thomas Melman at Howard University of GUTS. GUTS, for those who don't know, stand for the Georgetown Howard University Center for Clinical and Translational Science. It is my pleasure to welcome you to today's forum entitled The Intersection of Ethics, Data Science, Informatics, and Epidemiology. For those who are new to us or who need to be reminded, GUTS is a collaborative consortium conceived in such a way as to unite our top institutions in the regions, that is Howard University and Georgetown University, as academic institutions, and MedStar Health Research Institute, the Washington, D.C. Veterans Affairs Medical Center, and the Oak Ridge National Laboratories as three affiliated hospitals and research health systems. Our mission is to accelerate clinical and translational research to improve human health by fostering innovative collaborations among our institutions. And how we do that is by incorporating translational science principles in all that we do. I would be remiss if I didn't take the opportunity of the audience to mention some of the infrastructure and services that GUTS provides, which you can take advantage of as a member of one of the partner institutions. GUTS has a very robust pre-doctoral, postdoctoral, and junior faculty training program in translational research. You're welcome to contact, if you recognize any of these names, Dr. Sandberg, Dr. Dexter Lee, Dr. Carl Thompson, and Dr. Jason Humans at your various institutions for information about that. We also offer pilot funding for translational research and translational science approaches to improving health systems. And you can contact me or Dr. Melman for more information about this. And so GUTS has been a leader in data science, and you have with you one of our leaders, Peter McGarvey, but he's part of a team who has been at the forefront of integrating data science into clinical research and providing informatics resources, including access to curated EHR databases. So if you're someone who's interested in clinical trials, for example, we have a trial innovation network where we bring to you the opportunity to participate in some national clinical trials. If you're sent an opportunity, please read it carefully and consider responding. We are standing by, ready to help you in completing those trial innovation network interests. This is led by Dr. Kasaye at Georgetown, but we reach out to all of the institutions. Please peruse our website, www.georgetownhowardctsa.org, and familiarize yourself with what we have to offer in terms of community engagement, research support, and resources and education. So it's really important that you interact with us. So thank you for humoring me while I do this little commercial for GUTS for our institution. Okay, so back to today's forum. Today's forum builds upon our 2024 webinar on assessing emerging bioethical issues in the application of big data and artificial intelligence in clinical and translational research, especially research that involves underrepresented population. So today we're addressing ethical considerations at the intersection of data science, informatics, and epidemiology. As we harness big data and AI to improve health outcomes, it's imperative to address these ethical considerations, including, data privacy, consent, and algorithmic biases. Many thanks to the organizers who you will not hear from today, but merit recognition in putting together this symposium. Dr. Jane Otato is the director of REX, Guts' Research Knowledge and Ethics Core. Ms. Claudia Gonowen is a clinical research coordinator at the VA and has been on top of everything here. Ms. Priscilla Adler, and the entire Guts administrative team, really, including Angel NeQuain from Howard, who's a research coordinator. So I want to be sure to acknowledge all of these individuals. But last but not least, I want to thank Dr. Mark Blackman, who, although is not on the panel or moderating this time, has been a leader in organizing these functions for us and has been a great, great colleague. So now to the crux of it. This session will be moderated by Dr. Bethlehem Tobo. It's my pleasure to introduce her. She is an assistant professor at Howard University College of Medicine, where she oversees projects and mentors future healthcare professionals. Her dedication to social justice, health equity, and data integrity has been evident throughout her career. Previously, she led the Statistics and Data Science Core at Howard Center for Excellence, focusing on addressing health disparities in Washington, D.C. Dr. Tobo earned her PhD in Public Health Studies in Epidemiology from St. Louis University, and her research explores how social and economic factors such as income, education, and neighborhood condition affects health outcome. She's contributed to national projects aimed at reducing bias in health data and improving research capacity, especially at Howard University. Please join me in welcoming Dr. Tobo, who will guide us through today's discussions on this critical and very, very timely topic. Welcome, Dr. Tobo. You can take it away.
Thank you so much, Dr. Gondry Lewis, for that wonderful introduction and for outlining Guts' great work in advancing translational science. Before we begin, I'd like to highlight two quick housekeeping items. The first is that each session will include an expert speaker followed by a moderated Q&A. And the second is if you'd like to submit a question, please use the Q&A function at the very bottom of your screen. Feel free to submit your questions anonymously as well. We might not be able to address all of your questions, but we'll do our best due to time constraints. We do encourage active engagement as much as possible. Next, I'll provide a very high-level overview of this symposium and the structure of our event today and briefly introduce our keynote speaker. This symposium, as Dr. Gondry Lewis noted so well for us, is designed to explore how various disciplines intersect to shape health-related decision-making. Our panelists bring such a wealth of expertise in many different areas, such as philosophy, health policy, medical humanities, molecular genetics, biochemistry, biomedical informatics, data science, and regulatory frameworks, and this is just to name a few. The best part for me is that they are truly multidisciplinary thinkers and doers who are breaking down barriers and working beyond academic silos. We will begin with a keynote from Dr. Kenneth Goodman, followed by a short break. Then we'll move into two expert-led sessions, one by Dr. Kevin Fitzgerald and another by Dr. Peter McGarvey, before bringing all of our speakers together for a final panel discussion. Now, it is my joy to introduce to you our keynote speaker. Dr. Kenneth Goodman is the founder and director of the Institute for Bioethics and Health Policy at the University of Miami, and this is just one of his many, many impressive roles, which you can read more about in his bio that you have access to. On a personal note, and something that you won't find in his bio, is that I serendipitously met Dr. Goodman last summer and found our brief interaction so captivating that I bugged to follow up with him. Somehow, I've since then convinced him to mentor me and landed myself in this virtual space in a role I probably have no business occupying. The slight jokes aside, I wanted to sincerely thank Dr. Goodman, not just for being here to impart his insights, but for being an amazing mentor to me and to those who came before him, because as the famous saying goes, I truly stand on their shoulders. I promise this is the only time I'll slightly misuse my moderator privileges, but I did have to take a moment to pull back the curtain just a little bit on how someone like me ended up here after what I truly believe was a series of miracles that brought me to the States, and that's legally government who's listening. In a career landscape that can feel impossible to navigate, especially for those who see themselves in my story, I hope this serves as a reminder that doors can open in unexpected ways. And to those who are feeling that struggle more today than ever, I see you. Keep your head up. There are people who can and will look out for you. And just remember one last expression, which is that closed mouths don't get fed. Without further ado, I'd like to invite my brilliant mentor, Dr. Goodman, to give his keynote address, which will explore how ethics shape public health surveillance and data-driven decision-making. Dr. Goodman, the virtual stage is yours.
Dr. Tobo, I'm going to have to respond by also stepping out of my role a little bit. One, thank you very much for that very kind introduction. To be able to participate with colleagues from Howard and Georgetown and the VA, et cetera, especially in the context of the translational science initiative in our country, is a rare privilege. But the privileges of giving talks, as I hope you will come to realize, pales beside the privilege of being able to work with colleagues like you. Welcome to the United States. One of the things that, for those of us who are sentimental about our country, it is because of people like you and my grandparents and who came to this country, sometimes voluntarily, sometimes not voluntarily, but who now are here weaving a rich fabric of people committed, among other things, to science, to its role in justice, and to its role in the improvement of society. That's been a human aspiration for several thousand years. It has not ended, no matter what you've heard. So thank you for that very kind introduction. I mentioned the VA. Thank you all for what you do. But if you work for the VA, thank you for your service. I just got this thing in the mail. I don't know if anybody here ever collected baseball cards. I did. I got these things in the mail from the Tuskegee Airmen. Here's a picture of one of their planes. Here's the picture of the pilots. And I'm hoping, having made a donation, I get a nice Tuskegee Airman hat. I mention that only because history is a very important source of data. When we talk about surveillance, we talk about monitoring, we talk about data collection. What we're gathering at this moment becomes history in a few seconds. And if we're getting it right, we are doing this on an ongoing basis. This supports our colleagues who are doing the science, it supports the people who are analyzing the data, and it supports the populations we are duty bound to serve. Dr. Tobo, thank you for an extraordinary privilege. I am going to provide a couple of special digital incantations now, beginning with sharing my screen and launching these slides, which I hope will momentarily be hang on one second, slideshow. Are we seeing what we're supposed to see?
Yes.
Beautiful. Thank you very much.
It's the presenter.
No, you need to go on slideshow mode. The swap, yes. Perfect.
It's amazing how you click on a button and you think you know, and you think you're doing informatics. Dr. Tobo and I met in a context in a rarefied environment where people who are interested in public health science, including epidemiology, and biomedical informatics, which includes public health informatics, have discovered that there are interesting and important connections between these fields. Our colleagues who've been studying the spread of different maladies have known for a very, very long time. I'm going to give you some examples in a moment of how important this history is. But that intersection, picture a Venn diagram, public health science, information technology, and then the third circle is ethics. And that bit in the middle is I guess the sweet spot of this symposium today. And I don't think I'm exaggerating by saying that if you are interested in, concerned about, or committed to the health of populations, then it cannot become more important than that. All right, so I want to begin by sharing a bit of a reminder about all the different kinds of surveillance that we do, and we have done for a very long time. This is no particular order, obviously. We're talking this morning about the one at the end. But I mentioned business and financial surveillance in part because we're going to be talking about consent and privacy and that sort of thing. I don't think I'm alone who among those of us who pulls out a credit card or goes online, enters a credit card number, and buys something. I know full well that that click is a datum. Actually, it's a bunch of data, and it is gathering information about everything from my credit record to my credit worthiness to what it is I bought to the medium I used to buy it and so forth. In other words, there are many organizations, because it's their business job, to keep track of that to try and sell me and you more stuff. They do not, unless you click through as far as you might, ask for our explicit consent. We just do it because of the convenience. I mention that only because you ask the same people who click quickly as I do, may we use your information to improve the health of populations? And some of them get rather quite concerned about that. If you're going to give it to your bank, give it to your doctor. We also know about surveillance for the military purposes. In fact, the history of military and espionage is a great in ancient history. We're not talking about that today. Neither about law enforcement, where, as you know, some of the challenges that our colleagues in law enforcement face are ethical challenges that are perfectly parallel to these, although with a slightly different valence. Well, we're not talking about that today, but I wanted to frame what the kind of surveillance that I'm talking about, namely in epidemiology and health, but with particular regard to syndromic surveillance, as of a kind with others, using extraordinary and extraordinarily powerful new technologies. Okay. In the context of health, I want to share with you a couple of sources of data and information. And this is, as any of you who are familiar with this will know, is not an exhaustive list. Where do we get all these data from? Why have we been gathering them for thousands of years? What good are they? And how do they evolve? So obviously, clinical and insurance records are a great source, a powerful source of data. While we're concerned about scientists and maybe the government gathering data, no one ever says to the insurance company, I'm not going to let you gather my data, because they have us in a bit of a spot, right? If we don't let them have the data, they don't pay for our care. But the point is that is a valid, important, and rich source of data. There's mandatory public health reporting data for certain communicable diseases, for instance. Our country, and in fact, our world, has evolved over the past century by learning about mechanisms of disease, the way disease is spread in populations, particular and vulnerable populations, duties we have to those vulnerable populations by doing a broad variety of scientific projects. Okay. That research is important. Once again, a shout out to all the CTSI colleagues here. We also know we create various forms of registries. Some governments do it, some academic organizations do it, some professional societies do it. A well-constructed, well-designed, and properly curated registry can be a precious source of surveillance data. Laboratory surveillance is essential for anybody who works in a laboratory. Some of the stuff that we look for, some of the microbes, some of the toxins, we gather trends, we gather information about and track trends based on our colleagues who do laboratory science. We've also learned that social media is an important source of data, and people who do kind of surveillance by tracking that are, one, learning of its utility, learning of its limitations, and learning of the ways that we need to be careful as we analyze our data, that we do not too hastily identify a pattern when in fact it might be factitious. The job of an algorithm, as you well know, is looking for patterns in databases. In fact, oh dear, I will refer to myself as a senior member of the panel. Some of you remember when what we now call machine learning, we used to call knowledge discovery in databases. It's not as new as you might think. We've been trying to do this for quite some time. Look for patterns in the data. And when it comes to health, those patterns can be precious. Other things about social media, I don't know if you know this, I've learned that this device here used to be a telephone that has sensors in it. You know, the gyroscope in it orients it so but it would also be able, if I had a tremor, to detect my tremor. It might be able to detect my pulse, depending on the apps that I have. It's gathering lots of data about me. Data which I believe is crucial, one, for scientific purposes, including scientifically the importance of social determinants. The reason we need to track social determinants, the reason we need to know about language, education, race, ethnicity, and so forth is because that's what good science requires. That did not used to be controversial, and it should not be. If we are going to do data science, we must gather those data. Otherwise, we're impeding the very effort that we have launched in order to support the health of populations. And so on and so forth. I mentioned contract tracing. You can complete the list if you want. I want to do a little historic aside, though, by sharing with you the the work of the wonderful John Graunt of London in the 17th century. Uh, I love these old documents. At the in the 17th century, what Mr. Graunt did was in London, the neighborhoods were called parishes, and what he did was he started looking at what caused people to die. And he made a list and he tracked it over several years. Here's a partial list of what they call casualties. Um, by the way, this is only half of the screen. You could scroll down. Use your favorite search engine. Look up John Graunt and look at his table of casualties. The names are wonderful. This is from the 17th century. It's several hundred years ago. Pox and smallpox found dead in the streets. I don't think that's an ICD-10 code, but you get the idea. He was trying systematically to find out what it was that harmed us. Extra credit for anyone who can guess what the French pox was. I learned, by the way, that when we talk about data and stigma, it turns out that in different countries, they always named syphilis after somebody else's country, as if not our problem. We got that from somebody else. We got that from foreigners. This human inclination that is, I find, if there are any sociologists or anthropologists here, help explain it to me. On the one hand, what I said to a room full of students was, welcome. How many of you are not from the United States? And they raised their hands. And I said, welcome. We're glad you're here. At the same time, some of my compatriots want to blame you for stuff. Why do we do this? We welcome you with open arms at the same time we try. That's a human inclination that goes back centuries, if not millennia. In any case, that was John Graunt of London. These are the first actuarial tables, by the way. These were used by insurance companies once they discovered life insurance. If you know when and how people are going, well, you can't sell life insurance until you know when and how people are going to die, because then you won't make any money. And so being able to gather these data and make predictions is crucial. Fast forward, and we're still gathering versions of this data. We're concerned in a, gosh, is it okay, Dr. Tobo, to refer to a post-COVID era? I'm hoping so very much. But let's say it is the post-COVID era. We learned many things from COVID, not the least of which is all of the inequities and disparities and biases, not just in our healthcare system. We were mindful of those before, although I'm not entirely sure that we adequately addressed them. But we also realized it was possible that our computational tools can lens those biases and make them worse. But nevertheless, what I think is uncontroversial is that it would be socially and scientifically irresponsible were we not gathering these data in order to protect the health of our populations. Okay, why is that the case? And so it's important as a philosopher to remind you why it is we have some of these obligations. What are the justifications for syndromic surveillance? Collective harm reduction. We don't do this because we're curious, although it's good that we are. We want to encourage curiosity in our students. We do this because when we are able to collect and analyze data in a reliable way, we are able to reduce harms to our population. Harm reduction is a very important function of civil society, but certainly of scientists. Okay. The phrase here might require a little elaboration: uncontracted duties to others in civil society. I am of the view, which I hope is uncontroversial, that I have duties to other people without having explicitly agreed through some sort of agreement or contract that I have those duties. In other words, as we get on with each other in the world, in our jobs, in our schools, on the streets, in our places of entertainment, we actually have duties to each other. I was having a conversation with a student in my public health ethics class the other day, and I was saying, look, we've never met before. I said by way of the hypothetical. And then I did something. Dr. Tobo, if this doesn't go well, then I apologize. But I asked the students, may I give you my interpretation, my interpretive dance demonstration? And of course, the students are all raising their eyes. What is Professor Goodman going to do? And I said, here is my interpretive dance. And with your permission, I will share it. Thank you very much. Now, I can do that all I want in the streets and in class, but I can't do that in a crowded room because I might hit somebody. I have duties to not do that, even though I don't know the other people in the room. My obviously great creative inclinations are not unlimited. I need to take into account the fact that there are other people and perhaps other animals around me. In other words, I have duties to others, and so does everyone else. Now, identifying those duties is what we try and do in the world of bioethics and other forms of ethics for that matter. I think we have duties when it comes to the economy, when it comes to transportation, when it comes to environmental protection and so forth. But for our purposes, we all have duties to each other. And I hope that's uncontroversial. We also justify syndromic surveillance by pointing out that I and you and everyone I know and everyone you know and everyone they know has benefited from other people's information and data. The reason our public health authorities, the reason our nurses, the reason our physicians, the reason our psychologists, the reason all the people who take care of us are able in part to do what they do because they learned from others. My health is better than it would be otherwise because the people taking care of me have learned about what my conditions might be and how to prevent them from getting worse, etc. Because other people's information has been collected and metabolized in the service of public health. And so it becomes peculiar on my part if I were to say, no, I don't want to share my data because it's private in my data, when in fact I've just benefited from the data of other people who don't know me. It's a if you will, it's not a technical philosophical term, but it is a goes around, comes around school of being in the world. Namely, we have duties to each other. And if I've benefited from your duty, it seems like it should be there should be no objection to me having some duty of reciprocity. Okay. When it comes to preparedness and response, we learn over and over again, as we're learning now with avian influenza and others. If we're not ahead of it, then we are going to have a problem. We need to learn how viruses and other contagions spread. We need to learn how they mutate. We need to know what populations they are resident in. We need to know how, and so on and so forth. In other words, the stuff of public health science. We have thousands of years of demonstrable benefits by preparing for this sort of thing. It is uncontroversial. Do not let anyone tell you otherwise. We have a duty, I argue a moral responsibility, to gather these data in the service of public health. And also, it's never been particularly controversial. Most of us know what we get from our scientists. We are grateful to our scientists. We pay taxes to our scientists. I have, that's my raise my taxes button. I don't want to be a freeloader. If you need more money to do science and bioscience that makes me and my family well, then why would I not want to contribute to it? Another form of reciprocity, if you will. And I believe, despite what you might have heard to the contrary, that overwhelmingly most of our compatriots agree with what I just said. This is what we do in civil society. We marshal our resources to use the tools of science to help make us better. Now, there are a number of challenges, and some of those challenges have become, for reasons that I'm still trying to understand, controversial. Let me mention a few of the ones that are not so much controversial, but procedural, if you will. One of them is privacy and confidentiality. We do not need to surrender our rights to privacy and confidentiality to be contributors to data repositories, and hence to syndromic surveillance, where we know those data are going to be analyzed by very powerful, intelligent machines. How do we do that? We have scientists working now on different ways of de-identifying and even anonymizing those data. You do not need to know that Ken Goodman at 123 Elm Street has left toe boo-boo, LTBB, an underaddressed malady. I think that we need to get a new code for it. But if I had a left big toe boo-boo, and by the way, we try to tell our students, lose the acronyms. When we write notes and charts, when we communicate to each other, we do not need to show off about all the acronyms we use, because that makes it hard for ordinary people to know what we're talking about. In the current environment, remember, under rules from the government, from a wise and thoughtful government that actually is trying to help contribute to the health of populations, we are now required, as well we have for a long time morally, to share what we write in the hospital notes with patients. All those patient portals need to be accessible to patients so they can read what doctors, nurses, and ethics consultants write in the chart. There's good reason to believe, that is to say, there's evidence. I believe it's a powerful and yet to be fully tapped source for translational science, namely the change that allows patients to be able to review the notes that clinicians write about them. But the point is, I keep running into acronyms, and I don't understand some of the acronyms. I did a little experiment without anybody's approval, and I asked a bunch of colleagues in different medical practices what the acronym stood for, and they didn't know either. Acronyms are very domain specific, which means if you're not in that domain, you don't get the acronym. If we're trying to improve the health of populations and we want our patients and our citizens to be engaged, then LTBB, left toe boo-boo, if you don't explain it, is not going to be known to the people we are trying to support. Thank you for that parentheses. But the point is, we are able to protect confidentiality. You don't need to know it's me in order to add to the number of people who've got left toe boo-boos, or COVID, or HIV, or a behavioral malady, or a genetic predisposition. We are able to gather these data, and we're able to structure our databases and our analyses of these databases, in part because of translational science progress, where we've learned about trusted broker systems and other ways of protecting privacy and confidentiality. That an unheralded benefit, if you will, of both scientific method and also the NCATS program. What is the scope of consent? Do I need explicitly to give you my permission to analyze my health record? That's a challenge. I would argue that you do not, because I've already given it up to the insurance company. When I paid for the drug, you've already got it on my credit card record. In other words, I have provided on a regular basis tacit consent, latent consent, because it would be wholly irrational of me and anyone else to say, I don't want my de-identified data to be used to help other people. Why would anyone want to do such a thing? And so therefore, I think that we do not need fine-grained consent. What we do need is comprehensive transparency and disclosure. And we need to do a far better job in everything from communicating study results to writing educational materials for our citizens and so forth. In other words, I think we've got this. We can balance privacy and consent in the context of big data analysis for artificial intelligence purposes by a number of practical tools, some of which, by the way, have been practically advanced by clinical and translational science initiatives. On the other hand, one of the challenges demands for anonymity. I might just be selfish. By the way, no matter what you might have heard, selfishness is not a virtue. It's not a virtue in the economy. It's not a virtue in price setting. It's not a virtue in making a business. It's not a virtue in selling things. It's not a virtue in public health. It's not a virtue in your it's not a virtue. Selfishness is an impediment to the health of populations. So demands that I be anonymous, when that makes it more difficult for you to gather information about me, sabotages the effort to try and improve the health of populations. Also, another challenge is y'all are more familiar than I am with health literacy. Goodness knows we've got a lot of information technology literacy challenges. Might even say we have opportunities to improve our bioethics literacy. But a lot of ordinary people, well-meaning people, don't understand a lot of our science, and that I hypothesize makes them susceptible to peculiar arguments against science. Why anybody would want to deceive anybody about, oh, I don't know, pandemics or climate change or anything else remains an anthropologic mystery to me. But nevertheless, we have an opportunity, and hence therefore a duty, I would argue, to make sure that we improve the health of our populations by reducing ignorance in those populations. And I mentioned political opposition just in passing, in part because it is a practical challenge. I don't understand it. I do not understand why it is that ordinary people would say, yes, I have no interest in believing the people whose hospital and whose excellence I'm going to go to after that car accident, or after I get sick with this, or after I get cancer, or when I have heart disease, or if I have liver disease, or if I have lung disease, or a trauma, and so on and so forth. I believe them and trust them for all of that. But when it comes to public health, and when it comes to pandemics, and when it comes to reproductive health, suddenly I don't believe any of them anymore. I don't understand that, actually. All right. Transition now to, I believe I have reasonably gently, one, acknowledged the importance of the science that we have enjoyed on Earth for very many years, its success in improving the health of populations. Well, if you're going to get sick in 2025, not 1925. What is this right to benefit from science about? And I want to share a little bit about that. Not my idea, although I think it's a wonderful idea. Put briefly, ordinary people, I believe, enjoy a broad variety of rights. The philosophers in the room will enjoy a debate about what kind of rights we're talking about, where rights come from, are they natural rights, are they civil rights, and that sort of thing. A wonderful topic of debate. Let's just equivocate on right for now and say that if you're a human on Earth, and maybe, by the way, if you're an animal on Earth, it would be peculiar to not use what we have learned from science in order to make your life better. In the context of health, if you want, but also in the context of education, in the context of transportation, in the context of law enforcement, national security, aviation, you name the field, and it would be strange to say we've discovered some new way to make airplanes safer and efficient. Imagine some of them were saying, nah, we don't want to do that because too many people will benefit from that. You could argue that that would be perverse and peculiar, that right to benefit from science can be used by anyone, anywhere, without preventing or impeding its use by others. Reference there. I also want to, for those of you who still have some affection, if not respect, for the United Nations, the Declaration of Human Rights was modified in such a way as to say that everyone has a right to share in scientific advancement and its benefits. This was incorporated in oh dear, 1960 something, I believe, treaty to which 169 countries have agreed to be bound. Unlike other human rights, however, the right to science has never been legally defined and often is ignored in practice by governments bound to implement it. Note that, pin that, think about that for a little bit. In our country, in our beautiful democracy, we have rights that are counterbalanced by many obligations and duties. I do not have the right to do my interpretive dance in a crowded subway car. I just don't. I have duties to others, and with every right, therefore, one could argue, comes a broad suite of responsibilities. Um, I also want to suggest, I don't know if there are any moral relativists in the room. I'm not one. I believe that if we've gotten it right, we've gotten it right. And if you disagree, you are mistaken. A tip of the hat to my dear old friend and colleague, Father Dr. Fitzgerald, um, where I want to say, one, relativism is wrong-headed, and two, everything I've said is, he will correct me, of course, but I believe that what I've just given you from a secular perspective is perfectly compatible with most faith traditions. We have duties to each other, whether we've accepted them explicitly or not. Okay, syndromic science now produces a number of different challenges and opportunities, if you will. I would argue that under syndromic science or syndromic surveillance, we have a duty to protect privacy and a duty to protect science. If you believe me, we can do both at the same time. We understand we have duties to protect privacy, duty to security especially, sometimes security precautions. My institution is sending me new rules for email and for logging on every other day because we know there are bad actors out there in the world and they would love to hack into our databases. That makes it harder for ordinary people to use them as well. But nevertheless, you can use them without altering, copying them inappropriately, and doing other sorts of things. And therefore, we are able to protect privacy and confidentiality and maintain security while still being able to share results. I would like to have a way for ordinary citizens to look at all the databases that we do and to query them. You have this now, I should mention parenthetically. If you've not done this yet, use your favorite search engine to look up clinical calculators. Increasingly, machine learning, artificial intelligence calculators will, when you enter your very clinical data that you've gotten from your medic or your nurse into a chart, and these prognostic systems will give you, in oncology, the likelihood of you surviving 5 years. These are already available. They're available to the general public. They're utterly ungoverned. Many institutions use them for marketing purposes. But ordinary people have access, have the ability to query very large data sets. Let's ask people what they want to query, and let's make it easy for them to do so. Maybe I want to say, in my zip code, I've noticed there's certain challenges related to access to care or diet or transportation to the hospital. Hence the point earlier about social determinants, all of which are social determinants. I would like myself, Ken, on my home computer to query your fancy scientific database. In other words, an argument, if you will, for future conversation about the democratization of access to these databases while maintaining security, while protecting privacy and confidentiality. Syndromic surveillance, I realize, I believe, on broad scope, broad consent, if you will. For certain kinds of data, we might need to get finer grained consent, but generally speaking, there's a literature, I urge you to look it up, that basically shows that when you ask ordinary people, and that's important, ordinary people, not ideologues or zealots, may we use your information and your data, not synonyms, for these public health science purposes, they overwhelmingly say either, yes, of course, and or, I thought you were doing that already. It's a matter of public health literacy. How do you think we know the tuberculosis rate in our community? How do you think we know whether there's a measles outbreak in our community or not? Because we're gathering data, in part because of mandatory reporting, in part because of reports from clinicians, in part because of that sort of thing. In other words, consent can be tacit, latent, or presumed. A privilege which scientists have, which I argue is one that should be regularly acknowledged and regularly reinforced by letting people what we do, why we do it, and how it is we are serving their interests. During H5N1 many years ago, which began in Canada, our colleagues there developed a document to address how to ethically optimize the response to that pandemic. And the title of their report quotes from the Canadian national anthem. Yes, I'm going to quote from the Canadian national anthem, where it talks about being on guard for thee. In other words, in some sense, that's what scientists are doing. You are on guard for us. I think that is an extraordinarily good, beautiful, and wholesome thought. We need to earn it. We need to be able to be on guard by showing our work, showing our justifications, and contributing all the time to public communication around these sorts of issues. We've also learned hence about the need for trusted authorities. The most important word I will blurt out today is trust. We've learned that is the first and the alpha and the omega, you will forgive me, in the context of artificial intelligence. If I don't trust the data set, if I don't trust the algorithm, if I don't trust the people who are using it, then I'm not going to trust what you say you're doing to help me. Once again, we advanced a lot of that through the consortium of CTSIs and the development of ways of doing this kind of research. Trusted broker systems is one way, but there are other really innovative and exciting opportunities to analyze data that serves the people and gives them comfort that we've got it right in terms of their values. As I note, the common presumption, expectation, and reliance on these tools. Okay. The unexpected challenges include willful misinformation. I don't know why anybody would want to deceive anybody about public health, but yet we've learned in our world that there's some people who do. I'm vaccinated. I hope you are too. That's because there's overwhelming evidence that vaccines of all sorts reduce the incidence, prevalence, morbidity, and mortality. Mortality means dying of various kinds of communicable diseases. The cowpox discovered by Jenner came after John Grant, which is why they had all those poxes there. The number of lives we have saved through vaccination is too numerous to count. Anyone who suggests otherwise is doing something that I find to be very and highly peculiar. I think that sabotages trust. It creates instability. It leads ordinary people to be fearful. I can't think of any moral system, faith-based or secular, that says that's okay, because it's not. The challenge of diminishing civic and ethics literacy may be a way to describe all of this. I teach grad students. I make it a requirement that they read a newspaper, not the actual paper. I'm old. I love a newspaper. My grandfather taught me how you used to have to fold the newspaper to read it like this on the subway, which is why I know about crowded subways, which is why I cannot do my interpretive dance. Point is, if you are not abreast of current events, if you do not know about the science, if you do not know, for example, during COVID, how swiftly the virus was mutating and how that required that we be vigilant and we be nimble about isolation, quarantine, mask wearing, and vaccines. If you did not follow the science on that, you wouldn't know why you had certain duties, which is why it was dispiriting. There were some people who would suggest falsely that masks don't work and vaccines don't work. That's not what the evidence showed. Why would you suggest to somebody anything different? The challenge that I want to spend a little more time talking about before I conclude is artificial intelligence. As you know, artificial intelligence has been around for quite some time. In the decade of my birth, and I'll let you guess at that. It was no good back in the early days. It was the idea that we could write computer programs that would solve problems sort of like the way humans do. And what we have learned a lot over the last couple of years is artificial intelligence and machine learning are powerful tools for insight and deception. That there are many and perhaps inadequate governance mechanisms. I do like to collect things. When I play scientist, I try and look at patterns. The database that I created is the one that the link is there for. We were supported by a small grant from the World Health Organization. My institute is a WHO collaborating center in ethics. And we were interested in appropriate use and users of AI programs. And I started noticing that a lot of organizations have AI guidance. There's a lot of AI guidance. I started tracking it just to keep track myself, got to zillions of them and said, you better put this together, make it look pretty and put it on the web because other people might like to see all the different forms of guidance. In the informatics community, I think Dr. Toba will be able to share agree. There's an old joke. It says, we love guidelines in informatics. That's why there are so many of them. But that's not particularly helpful. One of the challenges we need to identify and these guidelines need to address is what is an appropriate user and what's an appropriate use. I want to be able to make sure that I am able to use your artificial intelligence programs to be able to predict whether there's going to be a measles outbreak. That's because somebody's kids are going to be in that classroom. I apparently do not know. Once again, this is not a political observation, this is a philosophical one, but there is absolutely no liberty interest in making other people sick. I don't get the assertion, but nevertheless, identifying appropriate uses and users of those programs is vitally important. I would like to broaden that as much as possible so ordinary people can, but we need to make sure that it's done in an appropriate way. As I mentioned earlier, there's a new science, not new anymore, but the intersection of information technology and public health epidemiology, if you will, produces public health informatics and a rich suite of interesting and important ethical challenges. We have not yet used this very much, artificial intelligence, very much for public health. It is a fertile and exciting area to explore. We're doing it in, what you've been reading about and all the hyperventilating about artificial intelligence began, as you know, a few years ago when the pattern recognition software got really good. So we can analyze images. And we got really good at supporting our colleagues in radiology and pathology and dermatology and ophthalmology. Images where you can get patterns down to the level of individual pixels that the human eye can't see. That was pretty exciting, raising it and leading us to discover there is bias in some of these algorithms. So be careful, just because it's a computer does not mean it is trustworthy. Then we realized that with large language models, that these programs are able to do still more exciting and sometimes troubling things. Troubling because we've realized they make stuff up, that they are biased. And if they're biased, that undermines the obligation we have, the bold-faced moral obligation we have to diversity, equity, and inclusion. That's a moral obligation, an evidence-based moral obligation, and not anything else. Please do not let anyone tell you otherwise. And that therefore, we have an extraordinary opportunity to start finding out ways in which we can use artificial intelligence software to improve the health of populations. And then obviously the idea that if we can improve education and improve it's actually called a field of public understanding of science. which you get from museums and newspapers and television and that sort of thing, as long, of course, as it's reliable news, reliable museums, and so forth. Artificial intelligence will help us just in case we improve public understanding of science. So the logicians here will appreciate the syllogism. I want you to imagine there was no systematic public health data collection at all. I'm talking food safety, mandatory reporting, tuberculosis monitoring, you name it. You would not want to live in that world. Hence, we have a duty to conduct syndromic surveillance. I want you to assume an uncontroversial obligation to protect privacy. Therefore, we need to conduct ethically optimized surveillance. Therefore, ensure transparency and appropriate governance, educate and include the people you seek to serve, and learn better how to use and how not to use artificial intelligence in the context not just of syndromic surveillance, not just for the sake of enjoying the right to benefit from science, but because many things are part and parcel of many of the obligations that we willfully took on when we became scientists, when we decided to serve students, when we decided to serve veterans, when we decided to serve different vulnerable populations. That is to say, when we decided to serve our compatriots and nothing less than people who comprise our civilization. Thank you so very much. I think it's time for me to shut up. Some of you may have had that thought already, and ask Dr. Tobo if we want to field any questions.
Thank you so much, Dr. Goodman, for that insightful keynote. I especially appreciated how your discussion of ethics and public health data use highlighted the importance of social responsibility, which is getting, I think, increasingly difficult for us to grapple with today, let alone putting it into practice. We do have time for a few questions from the audience. Thanks to someone who submitted an important comment, actually, that I think is a segue to a good question for you, Dr. Goodman. The comment raised an important point about the use of acronyms in healthcare data that you highlighted in your talk. And the person goes on to say that while these acronyms may save time for clinicians, they can also create barriers for patients and non-clinicians who rely on this information. The commenter suggested either getting rid of them altogether or perhaps standardizing a selected set with a key that's provided in electronic health record systems. So from your perspective, what are your thoughts, Dr. Goodman, on the best approach to balance the need for efficiency among providers with accessibility and transparency for all stakeholders?
Great question. May I share my favorite acronym that I learned?
Yes.
Which no one knew, and we finally dug it up. No BLT. No BLT. What do you guess that stands for? It's
Clearly not bacon, lettuce, tomato. What's that?
Oh, no. I asked a bunch of people from different specialties. The ophthalmologist said, wait a second, I think I know what that is. No bending, lifting, or twisting.
Mm.
So there are many tools. You have them on your computer, and they have them in all the leading electronic health record systems. They're smart phrases. It will complete it. If you type out CABG, coronary artery bypass graft, the system will automatically spell out the words for you. I've tried to do a little bit. When I write notes, as part of my job is I'm responsible for ethics services at the University of Miami Health System and also the Jackson Memorial Hospital System, which is our large tax-supported public safety net hospital in Miami. I write notes, and I'm thinking, if I actually type out chronic obstructive pulmonary disease. These are common acronyms, and many lay people know them. It takes me a little time. Chronic. If I add up all the time I've spent doing that in my career, how much time have I spent? Not that much if it improves my colleagues' understanding of my note. and an hour. I don't see. I'm a philosopher. I'm licensed to do absolutely nothing except drive a car, and they haven't even asked about that lately. The idea is that it's what I'm trying to make the case, and we've been talking about this at my institution's ethics committees for years. In fact, we've created the Acronym Mitigation Project, AMP, where we are, one, there's a literature on this. It shows that it can have harmful effects. We already know that all those weird Latin abbreviations could kill someone. Acronyms are in that cohort. They impede your colleagues' understanding of what you're trying to communicate in a chart. They impede your patient's ability to do that. If it takes you 2 hours in your lifetime to spell out words, given all the other stuff you do that you have to do, that's a good investment of your time. So one, just type them out, or two, use the tools internally that will auto-complete what you're writing. I don't think there's any excuse for it anymore. Technology gives us a solution to our acronym obsession. I even type it. Best known acronym in the world in ethics is probably what? DNR, right? Well, now we're using DNAR, which gets some patients. What's the A stand for? Attempt, to make clear that most resuscitation attempts fail. And patients need to learn about this not by watching television, which is how they learn about it, which is how they learn about public health as well, but by actually reading reliable information or viewing reliable information. So, great question.
Thank you for a great response. There's another question related to a point that you brought up in your address. This question asks, noting that we need, well, it's a comment leading up to a question again. So noting that we need transparency and disclosure, not consent, to use/share de-identified information for public good, is it morally acceptable to make care contingent on someone's agreement that their information or data can be shared?
Oh, I see we're out of time. Oh, Dr. Tobo, you didn't say it'd be a hard. So that's a great question. If you agree with me, and once again, I hope I said nothing controversial, but if you agree with me that because I've benefited from other people's information, then I therefore have a duty to contribute mine. My refusal to contribute to the common store of knowledge ends up being perversely selfish. We had this debate a little during COVID. You weren't willing to contribute to the health of populations, but now you need our help. I do not think the clinician should be in a position where anything they do or not do is part of some retribution or punishment. Even though we've got parasites and freeloaders, and they are among us, as we know, I do not want individual clinicians or our institutions to somehow have to be enforcers for that. We believe in due process, even if others around don't these days, and therefore we have a duty to not put a doctor or a nurse or somebody else in a position of saying, you didn't ship. Similar problem with organ transplantation. It says on my driver's license, I'm an organ donor. If I said, oh, that's yucky, I don't want you to have my kidneys after I die, would it be permissible to say, well, if you're not willing to share, we're not going to give you one if you need it? That's a little easier to justify because then you can document Ken didn't want to be an organ donor. Now Ken needs a liver. Well, sorry, Ken, you didn't want to play ball with us. You're a rarefied form of user, which violates every moral standard there is. And it'll never produce a benefit, for those of you who are utilitarians, never produce a collective health benefit. Selfishness never does. So I want to say moral suasion is better than compulsion or coercion. Great question.
Thank you to our anonymous question asker. And I agree, these are all great questions. So two quick ones before we transition in our program. The first one is, what are some ways that we can fill gaps in information gathering?
Well, it depends on the information, depends on the gap, right? One of the things that so I'm a philosopher, I've learned a little bit of logic and statistics over the years. And one of the things I find absolutely enthralling is what biostatisticians call missingness. We know our data sets are incomplete. We know they're buggy. right? Which is why we need to be really careful about the inferences we draw from them, even with our intelligent machines. But nevertheless, we have gaps in our databases. And so I'm looking for more science to support, for example, synthetic data sets that might help complete those, more research to do that by way of research and surveillance of the sort that we know already are useful, and so forth. In other words, my opinion is the best solution to questions about gaps in our science is more science. And I think that that's for any students who are here, any scientists who are here, we can't, civil society cannot thank you enough. What you have done is the reason some of us are as old and well as we are is look at life expectancy. Real quickly, and next year, can I get a budget for special effects? Here's a measure. Here's a measure of health, well-being on Earth before we add the following. Organ transplantation, left ventricular assist devices, extracorporeal membrane oxygenation, and genetic engineering. Watch carefully the difference in health and well-being of our population. You ready? You see that right there? Now, I would like you to see the benefits in health and wellness of the population of the people on Earth after we produce adequate sanitation and vaccination. And that's an embrace. Right? That's the way it works. Anyone who suggests otherwise is sadly mistaken. We need to do more science because that answers our scientific questions. And most of us know that, most of us believe that, and most of us are willing to support it.
Well, I clearly subscribe to all of your thoughts. Thank you
That
so
makes
much. Really appreciate such an insightful and rich conversation. To the last person who asked the really fun question, it's actually part of our panel Q&A, so happy to address that at a later point. For now, I did want to mention a couple of things before we go into a break. Dr. Goodman, again, thank you so much. So much gratitude to you for your fantastic insights. Before we transition to a short break, I did want to flag an evaluation that we would love everyone to complete at the end of today's event. Your feedback is extremely valuable and will help us improve future symposiums. Now we invite you to take this time for yourself. We will reconvene at 11:15 with our next speaker, Dr. Kevin Fitzgerald, who will explore the ethical complexities of gene therapy and highlight some AI regulations for us. So with that, we will see you back in 5 minutes. All right. Welcome back, everybody. We hope that you had a chance to refresh and take a stretch, whatever it is that you needed to do. We will now move into our first expert panel. It is my pleasure to introduce Dr. Kevin Fitzgerald, whom I like to call Double Doctor and Father Fitzgerald. Yes, folks, we have a Jesuit priest with 2 doctoral degrees in the virtual house, a fact that Dr. Jane Matado here at Howard University rightfully loves to highlight. His presence here is especially meaningful to me as a Jesuit-educated person striving to more fully integrate my faith and profession. Dr. Fitzgerald is the John A. Creighton University professor and chair of the Department of Medical Humanities at Creighton University, among, again, many other extremely impressive roles that you can see in his bio. In his talk today, he will explore the ethical trade-offs in medical innovation and touch on regulatory considerations in AI. Now, I don't want to take up any more of his time, so Double Doctor and Father Fitzgerald, the virtual floor is yours.
Well, thank you very much, Dr. Tobo. Let me just share my screen here. I gather that works. All right, are we good?
Great, thank you so much.
All right, perfect. Thank you. All right, and let me just say thank you to the organizers for this opportunity to engage with you today on this. This is a great topic. And I also have to thank Dr. Goodman. I could not have asked for a better introduction than he gave. I think he hit all the right notes. And what I'd like to do now is sort of raise the challenge of, even after you've hit all the right notes, do you get the fugue that you were after? So what I'd like to focus on, again, from that lens of developing technologies and looking for those benefits that we all desire, how do we best go about achieving that? And I think one of the things that we can do is look in other areas that are perhaps a little further along historically to see how things have progressed, what has worked, what has not worked, what surprises have arisen, and in what ways have challenges come to the fore that were not considered to be necessarily the ones that we were going to face. So again, my area is genetics, so I would like to talk about a little bit of the history of gene therapy and the ways in which I think it can illuminate for us the challenges that we are going to face and are facing with the implementation of AI in healthcare. So one of the things we like to do, certainly in ethics, when we ask, what are the things you are trying to achieve? What are the benefits you want? Because obviously that will have some impact on how you're going to try to get there and what risks you're willing to take along the way. So Dr. Goodman mentioned a great deal about improving healthcare. And oftentimes that is how we frame our work in this area. Why are we doing this work? Because we want to improve everyone's health. All right. However, Dr. Goodman also did mention that within the scientific framework itself, oftentimes there's the justification that, well, this will just help us know more. We'll learn more. We'll get more data. And from that, we'll be able to do perhaps some other things like improve our technologies, maybe in ways that don't have anything to do with healthcare. But all those things we could argue still would be considered benefits. And then, of course, Dr. Goodman also mentioned there's always this idea of costs. So maybe what we will discover will allow us to save money or improve profits, which, of course, from that business financial side is something that's always highly desirable. And then, of course, one thing we could all wish for is let's have it all. Let's just get it all. So, okay, as we go forward, think of the things that you're trying to achieve with the work you're doing, with the technology you're using. Because now we want to look at what might some challenges be, some hurdles, some obstacles, and in fact, some landmines that you might encounter along that path. So just to give you, again, a few historical examples, I think, which you are all already aware. This was one, and in one of my other hats that I've worn over the decades, I did get a chance to work with the Pioneer Seed Company, and they were very much at the forefront of trying to use genetic technologies to create better seeds that would create, of course, better plants and therefore better food. They were competing at the time, for transparency's sake, with another company called Monsanto that was taking a different sort of genetic approach. And of course, this all came out in the genetically modified food issue, which is still highly controversial. And here is a photo that, of course, somebody generated where the scientists, as you can see, safely ensconced behind the protective glass, are enjoying watching the children be transformed by this genetically modified corn they are eating from Monsanto. And again, this is just an example of how things can go off the rails in terms of what our expectations were. When working with the scientists and all, and again, I'm a human geneticist, I'm not a plant geneticist. That stuff is just way out there. Those people deal with much crazier chromosomes than we have to. But they were so excited. They were so convinced this was going to be the next green revolution. And yet, as we know, we just entered into this quagmire. Why did that happen? Where did we go wrong? In a similar way, in my area, more in human gene therapy, there were two incidents that both of which were not necessarily unanticipated, but the significance of them and the way they came about, I think, caused great consternation and actually set back the progress in gene therapy for at least a decade. And one was Jesse Gelsinger. Many of you may know that story. He sort of volunteered to be in an ornithine transcarbamylase. Sorry about the acronym OTC, but I couldn't fit ornithine transcarbamylase on that line. In a gene therapy trial. And his disease was not as burdensome as others, so he didn't need it, but he volunteered anyway. And sadly, again, in retrospect, one could say due to circumstances that didn't necessarily need to happen, he had a very strong immunogenic reaction to the viral vector that was being used, and he died. Shortly thereafter, they did another gene therapy experiment, this time for severe combined immune deficiency. Again, sorry about the acronym. But the idea was these are children, and you may remember David the Bubble Boy back in the 1980s and all the photos and stories about that. And these are children without a functioning immune system. So the idea was it's worth the risk, right? Because they have no functioning immune system, and this might give them one. The challenge that arose was the fact that, yes, these 17 children were successfully treated using this gene therapy, but of the 17, 3 got leukemia, and one of them died because of the treatment, because the actual genetic vector itself had lodged itself in a gene called LMO2, which is important in the regulation of blood cell development. So here was a really interesting dilemma. What risk is it worth taking to cure a child of severe combined immune deficiency if there's going to be this risk of leukemia from which they might die? Well, that really then threw everything into a conundrum. How do we balance these things off, and who does it? Who makes that decision, especially if it's a decision for a child? All of you involved in pediatrics understand those challenges. And then, of course, we've had most recently Dr. Ha, and he decided on his own to try to genetically engineer 3 embryos, female human embryos, to be resistant to HIV because father had HIV. And there were many problems with this clinical trial, if you want to even call it that, both scientific and ethical. But one of the things that came out from the trial, in addition to all of those problems, was again this trade-off. And the trade-off is, yes, we can look at the gene, which is called CCR5, which produces a receptor that sits on a T cell. And it is the one that the HIV virus uses to get into the T cell. And yes, we do know of people who are naturally resistant to HIV because they have this mutated CCR5 gene. But if we were to have everybody share that mutation, then there would be other transmissible diseases that we would now all be more susceptible to. So again, here is this trade-off that pops up that says, wow, we can do all these wonderful things, but have we considered all the possible consequences? And can we even do that? Especially when we're not even certain how things are going to go. So this is an article that came out of the Genetic and Public Policy Center, Rick Borchelt and Kathy Hudson, which were looking at the public responses to these things back in the early 2000s. And the interesting finding was that we may have not exactly understood public engagement, and again, something that we all want, as Dr. Goodman mentioned, in the best way, because we were seeing it in more of a one-way street rather than a two-way dialogue. And so from that report, you have this conclusion, and you can see in the conclusion that, again, people just being asked, a significant percentage said they did not trust scientists. And again, I agree completely with Dr. Goodman. And I think COVID did cement that. Trust is absolutely essential. And if we do not work to engender trust, whatever technological advances, as we will see, that we achieve will perhaps not get us to the benefits that we claim to be pursuing. And so here we got to get away from this deficit model of the interaction with the public, where we educate them so that they can think like us and understand like us, which will then, of course, make them automatically support our positions, which, of course, is also, if you read the literature, been debunked time after time after time. That is not how human interaction works. So my question as we go forward is, how do we best engage our public? How do we deal with that transparency? And most importantly, what do we do with things that arise that we did not necessarily anticipate that cause challenges that we, again, were not prepared for? So when we ask our questions about our technologies, whether it be genetic treatments or whether it be AI in healthcare or whatever technology you want to pursue, one of the questions is, with whom do we have to engage? Who are the stakeholders? And as you will see, I think that's an incredibly important question, and one that we are now having great difficulty with. Because when we talk about benefits, are they benefits for us in the United States? Are they benefits for us in high resource countries? Are they supposed to be global benefits? And if it's supposed to be global benefits, have we asked the globe if those are the benefits that they want? Or are we saying to them, oh, no, 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 you should want this because we want it for you? So I'm going to use the case of sickle cell anemia, and you're probably all quite familiar with sickle cell disease. Here's just a nice picture of what it looks like when those red blood cells, those erythrocytes, sickle. And you can see the difference in the shape, and you can understand why those elongated and pointy blood cells do not go through the capillaries as nicely as the rounded, soft red blood cells, the normal ones. So that's the problem. It is a global problem, and it is a global problem of significance. Nobody denies this, right? So in this little summation here, one looks in the middle, it says total sickle cell disease mortality burden is running somewhere around 376,000. And if you look just in children under the age of 5, right, 81,000 on average. So again, an enormous healthcare problem, and one that we continue to try to solve with a variety of means. One of those means now being the possibility of actually going in and addressing the situation with a genetic cure, a treatment which currently looks like it can be a cure, and not just for some, but for the majority of people who undergo the treatment. I am not going to go through this slide in detail. I give it to you because my slides will be available to everybody if you want to read through all this. But the idea here is on the left-hand side, you can see a more traditional way of either putting in a new gene or putting in part of a gene that is going to then add to the genetic information in a cell and allow it to make the hemoglobin that needs to be made correctly while there's still the mutated hemoglobin HbSS or HbS-bethal in the genome of the cell, okay? So you're supplementing. On the right-hand side, the idea could be that if you go down that little diagram here and look at this HDR here, again, lots of acronyms, sorry, that's what we do in science on our slides. The idea here is going in and actually repairing using CRISPR-Cas9 or some other genetic editing technology to repair the mistake. That's a level of precision that we're not quite there yet. However, what we have discovered is we can go in and turn on a type of hemoglobin that we have when we are fetuses, all of us. Why? Why do we have a different hemoglobin? Because as a fetus, you have to pull the oxygen from the mother's blood. That's how you get it. And the only way you get it is that you have to have hemoglobin that attracts the oxygen even more than the mother's hemoglobin. So you can pull it off the mother's hemoglobin and have the fetus be oxygenated. That's why it's there. You don't need it after you're born. And so after you're born, that particular gene is slowly shut off. And usually by end of 6 to 12 months, it's almost all off. Well, that gene doesn't have the mutation causing sickle cell disease. So what if we just turned it back on? And that is another one of the genetic treatments that has now been FDA approved. And that one is one of the treatments that is now being evaluated for broad use, or broad in the terms of people with sickle cell disease. So we have to ask the question, will this treatment get us overall the benefits that we want? And so I introduce you to, if you're not aware of this, this is the Institute for Clinical and Economic Review. And as you can see, they just try to bring together all the information, all that data that Dr. Goodman was talking about, pull it together with patients at the table. So this is an incredibly important additional piece. This is additional data that we need. What do the patients think? What do their families think? How do they see this? And then you have this evidence-based discussion. And you can see that their goal is to align our healthcare spending to make sure we get the most health we can out of the dollars we spend. Okay? And again, sounds like something everybody would agree to. Here are the two currently FDA-approved treatments. The one that turns on the fetal hemoglobin again is that Casgevy or Exa-cel. And the other one is Lyfgenia or Lovo-cel, and that's putting in new genetic information. So that sort of old-fashioned way. As you can see, what ICER or the Institute has concluded is, despite the current uncertainty, we don't yet know real long-term outcomes because we haven't had people around long enough who've had these treatments. Both are estimated to produce substantial gains in length and quality of life. Okay, two benefits, I think, again, most everybody would agree on. Here's where the interesting challenge comes in. These are very expensive treatments. These run in the millions of dollars, $2 to $3 million. What this institute did was to try to say, okay, at what price point do you get these benefits and make it worth it? And as you can see, they said if it's priced somewhere between 1.35 million to 2.05 million, then we're getting the benefits that we want. Well, that's quite a cost up front, and that is the problem. In addition, though, and this is where, again, it's important to get all the data, be transparent, as Dr. Goodman mentioned. Part of the cost of this is not the genetic treatment itself. It's preparing the patient to receive those genetically engineered cells back into their body. And that treatment many of us familiar with because it happens also in cancer treatment, where you have to completely ablate the bone marrow of the patient in order to make room for this new genetically engineered bone marrow that you're trying to put in. And of course, that treatment in and of itself is very serious and can have adverse events that the patient needs to know about ahead of time. So this is all part of that complexity. When you finally get to the breakthrough that you're looking for, it may not be as simple and easy and as cheap as you had hoped. And this, again, in a sense, is not new. We've known, certainly in the oncology world where I have done my work, that doing these kinds of genetic manipulations, many of you have heard of CAR T cells that we use for oncologic treatments, where you, again, genetically maneuver and manipulate the T cells. CAR T cells are not meant to be a one treatment cure like these others. So costs can run into the $500,000 to $1 million range or more. And so again, how are we gauging these benefits and what the costs may be? And of course, paying these costs, if you look at things as a zero-sum game, which I'm not always willing to do, but I understand it sometimes when you're doing budgets, that's what happens. Money going this way doesn't go somewhere else. When looking at these challenges, one of the options that arose in terms of trying to find a funder who could at least address the issues within the US. Of the 100,000 people in the US with sickle cell disease, not all of whom would need this severe a treatment as a gene therapy treatment, could we come up with a funding mechanism that might work? This was the one that was proposed. It's the Cell and Gene Therapy Access Model. And the goal was to find a way to, as you read at the end, improve health outcomes, increase access to cell and gene therapies, and lower healthcare costs for some of the nation's most vulnerable populations. But again, the lower healthcare costs are costs that have been tabulated over the lifetime of the patient. And so if you do this very expensive treatment up front, and it works, and it has had a very high success rate, then you would, of course, accrue those benefits, cost benefits, over the rest of the lifetime of that patient. But you have to put in the money up front. The way that was considered to be done would be using Medicaid, for instance, and using different states' Medicaid structures, right, to deal with the people within their state that could be benefited by these genetic interventions. If you look at, again, the overall picture, hospitalizations and other health episodes related to sickle cell disease cost the health system almost $3 billion a year. Now, if 50 to 60% of people living with sickle cell disease are on Medicaid, and 50% of people in the United States could actually benefit from the treatment. So that's 50,000, and half of them, that's now 25,000. And you're paying $1 million rounded off up front, right? Now we're talking $25 billion investment. And then it's $3 billion per year that you're going to gain back your benefits on a strictly cost basis. We're not talking about quality of life and all those other things, which of course have to be taken into consideration. But of course, nowadays people want to know the cost piece. Well, there it is. Okay. But under our current situation, the status of this model going forward is still uncertain. So our question in my area is, what happens if this doesn't work? And then what happens if it does work? Because all the states don't have the same proportion of patients who might be qualifying for sickle cell disease genetic treatment. So back to who decides? And do we make this decision really just within the United States? Should we be looking just within the United States to see how we want to move forward with this? Or should this be a broader discussion? Certainly, they're having the same discussion in the European Union. I'm part of an organization over there that is looking at ways to fund this with even nationalized healthcare services, because again, they too look at that upfront cost and say, not sure we can do that. And is this then only a question for high resource countries, especially when we know that the vast majority of people who have sickle cell disease to this extent are in the Caribbean and Africa? And wouldn't they benefit even more from not having the burden of caring for all those people with severe sickle cell disease? And if they benefit, wouldn't the entire world then benefit? So how do we frame this challenge? And perhaps the US is unique in its challenge because the majority of the people in the United States who are here with sickle cell disease did not come here willingly. They were brought on slave ships. So do we have a particular ethical obligation that maybe other countries do not? And how do we bring that to a global dialogue? What ways in which we could hold that dialogue do we need to consider, perhaps before we even start rushing ahead with the technology? The difference now is we've already got these technologies. They've been approved. The question is, who will have access? What will it cost? How will we scale this, or even will we? So these are the challenges that are facing the genetics world right now. And I think they are challenges that are going to soon be facing the EI world, if they aren't already, when you consider things like the power that is needed, the generation of power needed to power AI. And then where's all that data stored? Who has access to it? Who has control? So when we look for proceeding with engaging the public around artificial intelligence, who's going to decide what the risks are and what the benefits are? I mean, we involved in healthcare in the US can see many benefits, and benefits we'd love to share with others around the world. But that's not the same as asking them if those are the benefits that they want right now in their lives. And so at this point, Dr. Paskalev was going to give a presentation on sort of those myriad of regulations and guidelines nationally and internationally, and she is much more expert in that than I. But unfortunately, she has been felled by a pathogen and is busy fighting that one off. So what I'd like to do, just again, to kind of continue on this trajectory of asking these ethical questions, is suggest some ways forward. And again, maybe not ways that necessarily immediately come to mind. They come to my mind because I'm part of a group over at the Vatican, the Pontifical Academy for Life, which is kind of the Vatican's bioethics group. And in looking at artificial intelligence and what it might do for the world, both good and bad, the thought was we are not equipped to make those decisions ourselves. We need to be in conversation with other groups, and especially expert groups. And so, as you can see, on February 28th, the Pontifical Academy for Life got together with people from Microsoft, IBM, the Food and Agricultural Organization of the EU, sorry about the acronyms again, and the Italian Ministry of Innovation, which is part of the Italian government. And the idea was, were all these groups willing to have a conversation, willing to get together and communicate with each other over time to develop guidelines, regulations, to develop goals, to develop shared benefits and also risks, to be able to clarify where it is we really want to go, how we think we can get there, and what we're going to do when we discover obstacles we had not anticipated, especially those that might be more of a harm to the most vulnerable and not so much to those of us well-resourced. So as you can see, the goal here again was that larger human benefit, which again, Dr. Goodman mentioned many times. In a follow-up to that, a document has come out recently from the Vatican. You may have seen this word before, dicastery. Dicastery comes from the Greek. It's where the court of law was. And you can consider that pretty much parallel to our departments in our government: Department of State, Department of Defense, Department of Health and Human Welfare. So dicasteries are similar. So here's one for the doctrine of the faith. So in other words, what is it we believe? Here's another for culture and education. They recently came out with this document, again, Latin. So that's the language they use, but antiqua et nova, so old and new, right? Old intelligence, human intelligence, new intelligence, artificial intelligence. The reason I point this out is because I think, again, it gets to the motivations, the goals, the values that the Vatican, anyway, is bringing to this conversation. And I think, again, getting back to Dr. Goodman's point about the engendering of trust, the only way you do that is if you put your stuff right out there up front and let other people respond to it in whatever way they do, often in ways that you, even if you anticipated, might not want to hear. That's the really tough part of real, true global public engagement, is hearing what you don't want to hear. And so this comes from that document. This is paragraph 5. And so again, the goal here, at least of the Vatican from their perspective, is to contribute positively to the discernment, to that public dialogue. All right, we're not planning on telling everybody what to do. We want to contribute to that dialogue from our own experience and perspective and whatever wisdom has been gathered in our tradition. And in committing to that dialogue, look in the middle of this paragraph. The church is saying to the people within that community, parents, teachers, pastors, bishops, anybody who's responsible for handing on the tradition, to take this issue seriously, right? To look into it, not just to allow someone else to decide, but to get involved. Again, as Dr. Goodman mentioned before, right? This is something you would find, I think, in all major faith traditions and many of the secular ones, right? Commit yourself to the dialogue, show that you want to achieve benefits that are shared broadly, and make sure that you are going to be actively engaged. So all I'm trying to point out here is I think there are methodologies available to us to have these conversations, to have these constructive dialogues, which will, by, I'm going to say necessity, because of the diversity of humankind, raise issues that all people will not want to hear. Someone's always going to say something that someone else isn't going to want to hear. And we know nowadays in our world, that is not something we deal with well. So it, I believe, is up to us being those of us involved in this symposium today, those of us involved in education and in healthcare in the United States, those of us involved globally, all of us, to engage in these constructive dialogues, because I do believe that's the only way that we ultimately get to the benefits that we all purport to be pursuing, but are very, very difficult to achieve. And so I thank you very much for your attention. I look forward to any questions or comments, and most of all, any suggestions you may have. Thank you so much.
Thank you very much, Dr. Fitzgerald, for that really fascinating talk on the ethics of medical innovations like gene therapy, and for such an outstanding job highlighting the complexity of these challenges in practice. I especially appreciated your point about the work that we still need to do to earn the public's trust, as well as the extremely thought-provoking questions and regulatory approaches you highlighted at the end. We do have some time for a few questions from the audience. We can start with the last anonymous question that was submitted, and actually you and Dr. Goodman would be able to speak to this question, which is, are there any readings or thinkers in bioethics that had a profound impact on your understanding of the field?
Oh, well, I mean, yes.
Kevin Fitzgerald.
Yeah. And that just shows you that Dr. Goodman's got to get out more. Really, just for me, I mean, one of the, and I know Dr. Goodman also would agree with this. Dr. Pellegrino was an amazing person to have worked with and worked under. For me, he was one of my mentors. Dr. Leroy Walters over at the Kennedy Institute of Bioethics, also wonderful mentor. There were many people. The Kennedy Institute of Bioethics at the time and the Pellegrino Center for Ethics had phenomenal individuals and history of that. And I think nowadays there are still many people out there that we can listen to who are, I'm going to say, not just unafraid, but who are actually eager to raise the hard questions, who recognize that that's how you get to where it is you want to go, and not look for easy polemic answers that just make you feel good.
Yeah.
It's worth, as acknowledgments of leaders in our field go, I'm sure you would agree that noting the recent death of Tom Beecham,
Yeah.
who at Georgetown, one of the, in fact, if anybody knows, when lay people know anything about bioethics, what they know is Beecham and Childress and the principles of biomedical ethics. That's where they developed four principles, which I actually disagree with in a number of different ways, but everybody knows them: beneficence, autonomy, non-maleficence, and justice. It's been a wonderful framework. I disagree with it. Professor Bernard Gert, if you know him, Kevin, he and Tom had this, I've got a picture of the two of them together having a debate about something. What you see isn't how should we do bioethics, but I think Dr. Father Fitzgerald's approach is the right. We've been influenced in lots of ways by people we sometimes disagree with. That's what we learn from ancient traditions of respectful disagreement. We get that from philosophers. We get that from colleagues in the church. We get this from lots of different traditions. We're going to disagree. That's not a bad thing. Disagreement does not entail disrespect. And the more that we can learn from people in the service of answering your question, I think the better.
I think those are really outstanding comments to make. Thank you so much for those thoughtful responses. I don't see any additional questions in the Q&A, so I'll go ahead and pose some questions to you, Dr. Fitzgerald, that I know you've given a lot of thought to. In your presentation, you raised a concern regarding post-development social issues, such as access for all, which are often overlooked in the excitement to develop new technologies. So how might the development of AI and data management in general work now to avoid these social problems?
That's a great question. And actually, for me, that's an exciting question, because if there's a technology that is intrinsically structured to sort of bring about its own demise, it's AI. Because AI could come up with the questions that could be most challenging for AI to answer. And I think that's the part that is exciting for me. So, but again, as Dr. Goodman mentioned, and many people in the field of AI mentioned, is that how you, of course, build the software, how you build a system, what parameters you put in, right, often dictate the answers. So let's go out and find the parameters and the questions and the issues from those people who are not excited about this technology, who are fearful. Whether we consider their concerns and fears to be legitimate or not, that's not the issue. At the moment, the issue is let's hear them. Let's put those into the algorithms. Let's find out what we're not thinking of in terms of perhaps possibilities that we are not really just that focused on. So that, I think, is a real fascinating opportunity to use AI to better critique AI.
I couldn't agree more. Thank you so much for another thoughtful response. Well, this has been another really rich discussion. We do need to stay on course, so we will move forward. Many thanks again, Dr. Fitzgerald, for your wonderful talk. And for anybody in the audience who continues to have questions about either one of the earlier talks, please feel free to submit them in the Q&A. Now we'll move into a session with our final expert speaker. I have the pleasure of introducing Dr. Peter McGarvey. If you have been paying close attention to today's themes, you have likely noticed that our speakers aren't just sitting at the intersection of disciplines, they are actively shaping them. Dr. McGarvey is another prime example. He is the director of the Innovation Center for Biomedical Informatics at Georgetown University, among, again, many other notable roles you can view in his bio. His expertise spans multiple fields that he seamlessly integrates. If you've ever wondered how AI is transforming everything from biomarker discovery to clinical decision-making, well, you're in the right place. I'd rather not take up any more of his speaking time. Dr. McGarvey will now walk us through the role of AI in informatics and data modeling. The virtual floor is yours, Dr. McGarvey.
I'd like to share my screen. I just requested. Sorry, did you hear me? I'd like to share my screen.
Yes, sir. I just enabled that.
There we go. Are you seeing anything?
Yes, and we're waiting for the presenter screen, I believe. There it is. Thank you so much.
Okay. Well, the introduction was really over the top. I'm really not. I sometimes feel I'm not an expert on anything, but I know a lot. I used to do actually plant molecular biology. I made transgenic plants. We even tried to put vaccines in them at another job I had. And people were producing antibodies in them. But I went into informatics. I've already had all my titles. I am part of GUTS. co-director of data science for GUTS. We have a new, you see AI Collab on the bottom. That's a partnership with MedStar to use AI for healthcare. And the thing I don't have expertise in is ethics, but I will still talk about it. These are just some of the things we work on in healthcare. And these are the current landscape of healthcare, personalized medicine. It'll help administrate. We think AI will help all these things. And it's already done a lot with imaging and some other stuff. And a lot of people in the field, including the former head of Google's DeepMind, think healthcare are the easy wins for AI. They could be wrong, but we do believe that. And I was kind of scared when I got this invite to talk, because what do I know about ethics? I mean, we do say we're going to do ethical and unbiased AI. I definitely thought about the bias, and I'll make some things we're working on that. So I decided to look up. This is the about what people in AI were thinking stuff. This is from the American Medical Informatics Association. I'm a member of it in 2020, same time as Dr. Fitzgerald said about the Pontifical Academy. Apparently, a lot of people were writing principles about AI and ethics. This is from AMIA. There are more principles, but I notice it has autonomy, beneficence, non-malfeasance, justice, explainability, interpretability, and fairness, which I think fall into the fields of ethics, from what I've heard. There's some other things they want: audibility, dependability. This goes on: benevolence. Okay, that's good. And ethical and transparency. They are focused on vulnerable populations and user education. And they haven't changed this since 2020. In the business world, again, in 2020, we have this practical guide to building ethical AI for businesses. I did work in a startup software company once, and I do have a master's in technology management where I learned all the business lingo. And this is an AI-generated summary of, I think, a 10-page article from here, a practical guide to building ethical AI. You should be able to read it on your screen. The guide outlines the necessity of operationalizing data and AI ethics to mitigate reputational, regulatory, and most especially, if you read it, their legal risks for company. People, variety of companies have been sued for what their AI has done or said about things. And that's a big concern for business. And they actually talk about how to make this operational. It's a business focus, Harvard Business Review. So how companies can put this and make ethics part of their system, create a framework, identify existing data governance boards you have, change how you think about ethics, take inspiration from healthcare, which has systematically focused on ethical risk mitigation. Don't know if that's entirely true, but we are concerned about it. Thus, we have this seminars. A big thing they makes points of are the incentivizing ethical actions. In companies, they say they know where the money is going, and if it's not going into ethics, they probably will pay less attention to it. This is a summary of the whole document. It actually, the tool I use, which is Adobe's, actually had more, was also summarizing some other follow-on stuff in the article, and actually produced a summary that was as long as the original article, but all nicely formatted with bullets. And this is what the Defense Department put up again in 2020, but it hasn't changed. I checked, and their idea of ethical and artificial intelligence is to be responsible, equitable, traceable, governable, and reliable. And this is what they mean by it. Responsible, appropriate levels of judgment, responsible development, employment, and use of capabilities, equitable, traceable. These are all good. I'm not sure where ethics comes in. Reliable, governable. They definitely want you to be able to deactivate deployed systems that demonstrate unintended behavior. You can read more. They have more details on a few of these at ai.mil. I didn't see anything about doing no harm. It is the Defense Department. Then I asked myself these questions. Do we need a process to ensure ethical and non-biased AI and ML? Sometimes we will in some organizations before building anything really intended to be put in clinical practice. I mean, at the moment, we're just doing exploratory research, which gets peer reviewed at the funding and publication level. I personally have been concerned about mitigating bias because there's a lot of evidence of that because the data is often biased. I personally am more concerned about that. And as you probably heard, EHR data is messy, incomplete, it can have biases and needs a lot of cleaning, at least before you do much with it. So what I'm going to do now is tell you a little about what we're doing and give you some idea of how AI works. And you can decide what's ethical about it. I think we're doing pretty good. This is one study that I'm familiar with. I haven't done all of these, but people who work with me have. And this is one example of what people are doing for healthcare, machine learning to enhance predictions of non-small cell lung cancer treatment responses using immuno-oncology data. Immuno-oncology is where they use certain inhibitors to actually, usually your immune system doesn't react to your own cells. And that could be a problem. It doesn't react to your cancer cells, but there are ways with certain inhibitors you can switch that and try to turn on the immune system to attack your cancer. It seems to work very well in some people. There's a genetic component, not in others. You'll see there's a lot of data curation. There's a registry produced by Georgetown and Hackensack Cancer Center. They take all this data, patient-reported outcomes, molecular profiling, EHR, therapy, physician's notes. They do NLP to mine physician's note. They have clinicians and medical students help curate the data, go find out missing data or standardize it. And for this study, there's only 213 patients here. This is a big problem getting enough data because you have to combine data from other institutions and that's difficult. We do feature selection, split the sets. This is common for any machine learning. You run it through a bunch of standard machine learning models. Then you evaluate the performance and try to figure out which factors are the most. Wait a second. There we go. These are areas under the receiver operating curve, these AOREC curves. These are commonly done for these models, and you see which one works best. And here it's one called K nearest neighbors. This is a shape value analysis and stuff that tries to predict the features that told the most about the outcome. And what's called the ECOG, the top one, is just basically a scale that's widely used tool in cancer treatment to gauge a patient's ability to perform daily activities. 0 is fully active, and 4 is completely disabled. And I guess it's not a surprise that that came up on top. This is red cell distribution width. It's a blood test parameter that measures the variability of red blood cell size as emerges as a potential prognostic and predictive marker, particularly in cancer treatment. Another blood marker is MPV, refers to mean platelet volume, a measure of the average size of platelets in the blood, which can be a potential biomarker for cancer diagnosis. Now, one thing we've been investigating for a while now is, can synthetic data help? Synthetic data is where you take these are also machine learning models and stuff that you take a real set of data, de-identified in this case, and you can build synthetic versions that mimic the distributions, statistical distributions of the real data. And why is this useful? Well, almost every AI and machine learning technique always wants more data. I mean, more data makes the models better. It can make them more accurate. And this way you can expand the data set you have. It's not large enough, you can make a larger one that mimics the data, and it actually will produce better models. There, at least some people have got it to produce better models. You can mitigate bias in the data because you could expand just one set of it. If you need more women, you only got 20% women or something, you can take that, make a larger set that mimics the women. You can do that for racial demographics and other things. And people have reported that that helps with machine learning and AI. So it can help with research and training. And that's one way to mitigate some biases. That's why part of the reason we're interested in it. This is the real data, the blue, and there's a couple different things we did for the synthetic data things here. It'll have some problems without you building in some weights or reformatting the data right. You'll notice that this is female, this is male. There are really only 3 with breast cancer in this data set, but the synthetic doesn't know the difference between algorithms, don't know the difference between male and female. So you will, and other peoples and models have this problem too. You will get some things that don't make sense regarding to sex. You'll get prostate cancer in women, but there are ways to fix that, and we're working on those. There's also some problems for it getting the right levels of medication, but I think we have some fixes for that. We're trying. And we're also trying to see if we can use that synthetic data for social and environmental determinants of health. You can see I haven't spoke to this before. Though I have to say the other day, we had to take that term down off of a website. It was decided to be too controversial, so we called it non-medical factors related to health outcomes or something similar, which this is how the CDC defines it now. Anyway, here's one experiment we did. We took real clinical data, joined it with FIPS codes. These are geographical codes. They're considered not specific enough to identify people and stuff, and joined it to real SDOH data sets. We also took this, made a synthetic set and joined it, and we're trying to compare what works better. I think this approach should work better. So then we took, so this was synthetic, we joined with the real data, put it through. This is the GAN model, which is one of the synthetic data generation models, and we're comparing them. And it's not perfect. I mean, the real data is over here to your left, post-join and pre-join. think the pre-join works a little better, but you can see places in the real data that aren't, locations that are not showing up at all in this. So we're working on fixing that in the next week. And another thing we're doing in our lab is we've been doing this for a while, gene variant curation. Now we're using LLMs for ClinGen. This is the Clinical Genome Resource. It's a large multi-institution consortium that's, well, one of the things they do is they curate gene variants. I mean, this is an active field. People are determining what gene variants actually affect the disease or can affect the treatment. It's a difficult thing, but as more data is accumulated, they're getting more and more accurate. And there's curators that do this from the literature. We've been working on automated ways to do this for several years with various collaborators. And also we're working with CIVIC, which is the Clinical Interpretation of Variants in Cancer. So they look at tumor mutations. And certain mutations are diagnostic and can inform your therapy. They can tell you certain drugs may work or certain drugs may not work. The way we do this now uses large language models. This is AIM-1, AIM-2, AIM-3, because it's from a grant. I won't go over it all. Most NLP was done by other methods in the past, but they've pretty all gone to AI-related models and stuff. We use a BERT-based NLP tool now. It was developed by Google. And the process for the grant is we're going to run these things through BERT, and I'll explain a little more what this means, generate LM prompts, and see if the large language models will give us a nice description. This is for curation of what the variant does, supported by evidence, which is connected here. The BERT is collecting variant disease relationships, evidence, and sentences that support them. And we're going to doing it manual validation will enable us to automatically create curated summaries. There are people doing this in other databases, not directly for this purpose and more for like describing what the literature has for small RNAs. They only have one curator, but they've done techniques like this using prompts and other methods to actually automatically put the curation in. And it's when you go to the database, you will see that it was generated by AI and they'll ask for responses. I want to say a little bit about this retrieval augmented generation RAG framework. It's very popular because what you can do, here we use BERT, put stuff into this database, but you can use other inputs. This is what you call a vector base of embeddings. Embeddings are what AI uses, what computer uses. Everything you do for a large language model gets put into a matrix of numbers. Embeddings are mathematical formulas. But if you do this, you can supplement it with the large language models. So you can actually give them a database they can read, because the large language models, you know, ChatGPT and stuff, they're trained on piles of data and stuff, but they don't have everything. This is a way you can query them and they can reference this vector database and the trusted sources and the data you wanted to know about, and they can use it in their answers. And this is a powerful technique that a lot of people are using. I'm going to say a little bit about embeddings because they're important. Some people don't realize this. I mean, computers work in numbers. Embedding converts raw text, images, and other data into numerical vectors, allowing computers to understand it better. There are different tools and methods for doing this. Computers only think in numbers. They can't understand human words independently. Text embeddings make it easier for computers to read. to understand the text. And they can use them for searches. This BERT model we're using has demonstrated a very good capability in producing in multiple languages, sentence embeddings over 190 languages. It doesn't just encode the letters or the words, it actually takes into account what they call the distributional hypothesis, which states that words or phrases that appear similar in context tend to have similar meanings. For example, the words king and queen, they're not synonyms, but they share a similar context related to royalty and monarchy. And these embeddings will make a three-dimensional matrix that computers can understand. This is an example from somebody else, not my work. It's actually about cancer from a colleague. He has a tool, you can rotate this stuff. And if we use these embedding techniques, similar contexts and similar things cluster together in it. And here these embeddings have been further clustered. You can use some other, this is principal component analysis. And all this is medical data. Okay, the colors in this representation represent certain types of cancer. The tool, I could put words on it, but it's kind of messy. So if you see all these blues and more of the blues over here, they're talking about the same type of cancer. And just the embeddings themselves help cluster some of the similar content. Now, this is more than just the name of the cancer. This is actually other health records, clinical data related to it. I think it's a cool figure. These are just the embeddings themselves, but large language models, like I said, you can make a database and there are tools you can do this yourself. You can go, Google has tools. You can put a book you like or something you believe in that you think is a very trusted source. You can load it and then query the large language model, and it can use that data to help in your answer. This is very powerful stuff. There's a few things I'd just like to mention. That large models are great, but smaller ones, you can have smaller fit for purpose models. I mean, none of us can make, what Google and Microsoft do, these massive models, massive amounts of energy and stuff. You can make a language model on your own computer. You can get a book from Amazon to do it, step by step, showing you how. And here you can take smaller data sets that really fit for a purpose, and people will do this. I know of people using other clinicians at other hospitals using imaging, simple imaging software, and it's on a laptop. I mean, no, actually, no, it's on an iPad. So it's a small model, but it can classify risks of various diseases. You can just carry it around. And that's it. I hope I've covered something interesting. I'm happy to answer questions. I probably forgot something.
Thank you so much, Dr. McGarvey. And if there's one thing I've learned from our last two speakers, it's that I must now practice my respectful disagreement with you about your expertise. I learned a lot. Thank you for that excellent talk. I especially appreciated how much you value and center your work around mitigating bias in health data, particularly through your use of synthetic data. We do have a couple questions from the audience that we'll have time to address here. The first question is this: in your research, and I've paraphrased this just a little bit, have you encountered instances of AI hallucination where the model creates false or misleading information? And if so, how do you identify and address these errors to ensure the integrity of the output?
Okay, there's several things to say on that. Yes, I've encountered it. Probably the first time I asked ChatGPT to summarize something for me, and I discovered And I asked for references, but all the references didn't exist. It perfectly formatted database identifiers. I know a lot of database identifiers. I can just tell by looking at it what database it came from because they have particular formats. And they were perfectly formatted. And I went to the database and there was nothing there. So these things happen, but there is prompt engineering, and you can actually prompt these models to say, okay, I want this with real references and other stuff. Using that RAG framework, I said you could load in piles of references and other data and ask the question, and it could refer to that and pull out references. I don't have a lot of personal experience, but I know people have worked quite hard on this, and they've published some papers about how they prompt and how they can add in other data to get rid of the hallucinations. And there's also what they call reasoning large language models now. Claude is one, and there's a few others you can Google about reasoning, where they're kind of designed that you can ask them, at least. Sometimes it will give it, sometimes you ask it for it. They will give you some idea of their reasoning. And another one is this new DeepSeek from China and stuff. So you can ask it, well, how did you get that answer? And it will try to tell you. Now for math, it's pretty good. It'll say, well, I took this, and I multiplied them, and we did this. But they will do other things and say, well, I looked at this data, and then I looked at this. So it can give you an idea. The problem with large language models is they are huge. These convoluted neural networks they use are complicated. For regular machine learning, you can leave certain factors out that you trained them in and say, okay, this is why they gave that answer. But it's really hard for the large language models because there's millions of nodes, and the nodes just have little probabilities in them, and you'd have to trace through so many. You can't perfectly know what they did, but that may change. They have reasoning models. You can look it up. And it's, I mean, a lot of this are new. I'm still playing with them too. Things move so fast.
They sure do. Absolutely. Who knows what type of conversation we'll be having in just a couple of months, let alone a couple of years.
Yeah.
Yeah, thank you for that response. The second audience question that I'd like to pose to you is, how do you ensure synthetic data are used to train healthcare LLMs or large language models accurately represent diverse patient populations and avoid perpetuating biases?
Well, I don't know. It's a research project now. We're still trying to prove it to ourselves what other people have said. I mean, well, I mean, a lot of EHR data has just natural biases. They don't have all ethnic groups, or a lot of data sets that don't have enough women. So we can try to balance that. We look at it ahead of time and try to balance it and see if it does better. But I'm open to much more other ideas. Testing. Amia will tell you, and I actually, when I go to some lessons, some people will say, look, you build a model, it's only good on the data that you built it on until you test and test and test on other data sets. That's really the only way, or you get really massive data sets, because it's commonly seen. I know of a person, they wrote a grant, we didn't get it with them and stuff. He's an engineer with a medical degree. They have an image analysis software that worked really well when they developed it. They got it FDA approved, but when they put it in other medical centers, it does not work as well. And part of it is, I'm not really sure. Their data might be somewhat different. He said that it's also hard just to get it in the clinical workflow, which just can mean getting the answers. And however, I don't work in a hospital. I mean, how they work or getting the answers in time to the right person. But yes, they had it FDA approved, but frankly, it didn't work in other medical centers as well. So you really need to test. You really need to test.
Sure. Yeah. Yeah. Those practical limitations that happen after the fact, right? Those are challenging. Well, this has been another excellent discussion. We do need to move forward with our program. We appreciate everybody's continued engagement. And Dr. Margarvey, thank you so much again for such a great talk. I will now invite all of our panelists together for a fuller discussion on the diverse topics that we addressed. We do have time for more questions from the audience, but I've made note of a couple that we will begin with. So I'll just give us a second, maybe. There we are. Okay, now we can see everybody. So Dr. Marjorie Gondry-Lewis asked, and this is actually a question probably more tailored to Dr. Goodman, but anybody else can feel free to jump in. So she made a comment, I appreciate the perspective that sharing health data is a moral obligation to society, which might enhance availability of data and catapult discovery. How do IRBs ensure that there is not an overcorrection in the opposite direction and still facilitate scientific discovery?
Is it an overcorrection by too much sharing? I'm not sure I clarify a little if you can. Look, we've known for a long time that stuff we learned as children is very hard to do as adults. Sharing is a really good thing. Sharing data about the health of populations is it's not particularly virtuous. I would argue that it's something that, especially when taxpayers pay for it, they're not paying for it for one community or one tranche or one level or one sector of people. They're paying for better science. And there are impediments to sharing, which I think are often overstated. One of them is intellectual property. I don't begrudge anybody, benefiting from having a great idea. However, and in fact, Kevin can address this better than I. We've learned for a long time that there's some things you can patent and some things you can't. So we couldn't patent a gene, but we could patent the assay by which you identified the gene. Well, I don't mind someone being able to take what they've discovered and realize some social benefit from it. But that cannot, I believe, or ought not be at the expense of larger, broader, more important shared values. Namely, there's plenty of career opportunities out there, but if your goal is to improve the health of populations, and you have the privilege of enjoying research support, be it from taxpayers or corporations or foundations or others, then we need to find a balance between the two. And IRB might overcorrect by not being mindful of those things. It raises a much larger question, namely my concern, and I assume this is not controversial, that we need to provide much more support for our colleagues on institutional review boards to be able to analyze 21st century science. They're looking at randomized trials as the only thing they know. But when genomes are digital and when you can run very, very large scale studies without there being any new blood or any new people, but where you're dealing with human stuff or human information, IRB still need to manage that. And we have not provided adequate resources for our colleagues who do research ethics review. And so the best answer, the easy one in the circumstances, unless you want to spend, well, I promise I'll be done by midnight. No, that won't do. We need to provide IRBs with adequate resources to be able to make judgments about human subjects protection in the context of different kinds of risks, harms, and wrongs. And I'm feeling optimistic today, so I think we can do that. But it requires resources. It requires development of educational tools and all kinds of ongoing, sometimes institution by institution specific support. We have IRBs not because a bunch of people in academia said we're concerned about human subjects protection and we want to make sure we do the right thing. We have IRBs because the feds are going to send in the black helicopters if you don't. That's because our history of human subjects research from Manchuria to Nuremberg to Tuskegee is not a particularly good one. And we need to make sure that we protect people who are purporting or were claiming to be able to support. And striking that balance, somebody who's ever served on an IRB knows, can be tricky. We're not going to get it Goldilocks, right? We are fallible. But openness, ongoing assessment and evaluation, and educational support, I think, is one way to begin to answer that question.
Great, thank you. And I think you interpreted it accurately. Unless there's anything else that Dr. Gondry-Lewis would like to clarify.
Just on that note, I
No,
mean, I agree with
yeah.
what Dr. Goodman said. They are horribly under-resourced. One additional thing we can do is all IRBs are required to have community representatives. And unfortunately there, it is difficult at times to get the diversity of community representation that you really should have on the IRB, especially when you're engaging, again, with underserved populations, right? Because you're not getting their perspective. And so part of that resourcing needs to address that challenge. How are we bringing in our community representatives? Are we making sure that we're hearing from the various groups we need to hear from to get all those perspectives to make the best decision we can on the IRB?
Yes, thank
wish
you.
we weren't so concerned about some of this stuff. We could do so much more if we could get more data. I go to meetings and see what some of the Europeans are doing, and I say, we could never do that here because they have national health care and people seem to trust it more. And they have huge databases of data, and they make advances that we're behind on.
Yes. And I think my concern is that we do have a blemished history here in the United States. And so we've put a lot of these protections in place precisely for that, which kind of cripples our trust of releasing data or how data is used. But I just wanted to say that I appreciate the perspective of the ethical thing being to share data and to have agency and a responsibility towards society. And I think we need to educate, right? We need to say more of that to those who matter, to the community. And the community does, it's not as bad as we thought in the past. They always said minority populations are not trusting of these types of research. And that's really not true, because when they're around the people whom they trust, they don't mind participating in these types of studies. And so I appreciate the revamping that's necessary. I think IRBs are kind of behind the times, in terms of catching up with what AI is and what it has to offer, and just casing that in the context of the ethics, right? Because the ethics are most important to them.
Great. Thank you all for your contributions. There's another question for this discussion, and it's there's a lead up to it. It's often said that an AI model is only as good as the data it's trained on. Given the ethical concerns around accessing health data, particularly how patients may be willing to share it for the greater good, but are concerned about misalignment and incentives, what do you think would help in accessing data while ensuring ethical use with the aim to improve an AI model for better outcomes?
Well, the models get better with more data, which is difficult to get. And the data is messy. There's missing values.
What do you think, Dr.
I think it will get better in hospitals because the companies that run the EHRs are all building stuff in, and they will be able to build predictive analytics that at least the physicians can use.
So here's a follow-up related question for you specifically, Dr. McGarvey. So one thing that I think about is how AI systems are often designed to favor structured data, those that are highly organized and that have predefined formats like numeric lab results or billing codes. But then it's usually the unstructured data, such as provider notes and patient narratives and more qualitative responses to survey questions, that hold critical contextual information that the structured data alone may not capture. So as an example, structured data can tell us that a patient isn't refilling their prescription, for example, but then unstructured data would be the ones to reveal maybe it's transportation barriers or financial concerns that are underlying the issue. And so given your expertise, is that, is the fact that AI models sort of favor structured data part of the problem here? And then how do we build models that help us integrate the two so that we have insights from both types of data?
The large language models don't necessarily favor it. We do mine clinical notes, which aren't that structured, though they use acronyms and language that some of us don't understand. So it's possible, but yes, getting those other things. There's a lot of groups working with just chatbots for community stuff to like communicate with the community, and people seem to like that. At least the reports I've heard and stuff, and they will happily chat to them or tell them things about their day. And this data can get back into models if people choose to use it that way, I suppose. But yeah, I see a lot of grants proposing those things.
Sure. Thank you for that response. I don't.
A friendly amendment, if I might.
Oh, please.
There are so many tools out there. There are now, Peter, is it the Hugging Face leaderboard? That there are different, many of them, some of them are the good version you have to pay for. So there's some proprietary considerations here. But we don't have near enough research comparing all of the large and small language models, especially given different data sets. The model's not going to prefer it. The actual algorithms are agnostic. They're just sort of eating what's put in their mouths. And I think what you want to say is, here are ways that we've discovered that different programs respond to the same data set. I think that's just good science, and we don't have enough of that. And it would be useful, I think, for comparing lots of different kinds of things, including the structure of databases, the comparative utility of different kinds of language models, be they small or large, and that sort of thing. We've learned so much of a new science in such a short time. Your grandchildren, Dr. Tobo, will look back and say, look at all the cool science they did after they discovered artificial intelligence. But we need to do the science, and it needs to be resourced. I think that was Peter's point.
Hugging Face, a lot of them are open source models and stuff, and it's cool. People, like I said, people are doing stuff with smaller models, fit for purpose. They can rank them on certain things. You don't have to use Google or ChatGPT and things.
If you compare two on the same data set, you get different analyses or predictions or whatever. That suggests something interesting. What is it about the data set? Was it somewhere in the process from data to synthetic data? Was it something about the algorithm here? And what happens if you add 3 or 42 of these programs to look at data sets? We're learning about data sets and algorithms what we were trying to learn about molecules 200 years ago. And I think that's an exciting scientific opportunity.
I agree. And, you touched on this a little earlier, and I want to hear more from all of you. Each of your areas of work and just the collective body of work that we've discussed today, it's constantly changing and presenting new challenges. And so could you tell us how you stay motivated and continue to innovate in this really complicated, ever-evolving landscape?
Well, for those that work in healthcare directly with patients, the motivation that I hear all the time is their patients, right? I mean, in spite of all the challenges of the EHR, in spite of all the systems challenges, in spite of all the paperwork and logistics and all that, what gives them life and motivates them is the fact that they are right there with another human being and helping that human being. And I think we can scale that and say you don't have to be a clinician working directly. You can be in public health, you can be in informatics, you can be in whatever. Where we get caught up, I think, is in the idea of what benefits for whom, who gets to decide, who gets to determine what the benefits are going to be and what the risks are going to be. Because we can be very motivated to do something and discover that what it is we're doing is actually something that is not desired by the group that we're trying to help. I think that's the big lesson to still be learned from the agricultural industry with the genetically modified organisms. I mean, they're still fighting that battle. And there's still this huge disconnect between this idea of trying to make plants better and how you do that, and this idea of, what am I putting into my body, what's natural, all that kind of stuff. And from a scientific perspective, it just evaporates. But from a societal and cultural perspective, it's huge.
Remember, one of the
Actually, on
challenges.
go ahead.
No, you please.
I mean, since I worked in plant molecular biology, I feel that it's actually hurting. It's hurting the poor, less developed countries because the resistance to it in Europe and the US, especially in Europe, is great. I mean, I worked with many scientists, we only got these crops and we got to make them more nutritious and we got to make them drought resistant because climate is changing. And genetic engineering is the fastest way to do it and stuff. Plant breeding works too, but it takes people their whole lifetime to come up with a new breed. And yeah, we don't need it. It gets, for whatever reason, Monsanto stuff gets better yields from corn. They don't really know why. It wasn't just making it Roundup resistant. I feel it's actually hurt because the scientists there want to do it, but since there's resistance in some markets here, I mean, you're just putting one tiny protein in most of the time or something.
Would you agree then that given the extraordinary potential for reducing hunger in the world, that the model that's used in Africa, for example, doesn't require they destroy their seeds and buy new stuff every year?
No.
Right. In other words, I have a lot more trust in GMOs if it weren't for the fact there's a business model that says you got something that farmers have been doing for 14,000 years is now illegal under current contracts. You got to throw out your seed and buy a whole new batch next year.
Right.
So while we can talk about hunger, I think shareholders at some of these companies might have different views.
Well, the biggest problem with the way we do it, at least in the US, is it's just makes a monoculture, and monocultures are a risk of getting wiped out by new diseases and things. But I'm talking about scientists we worked with and stuff over in Mexico or in Africa and stuff, and they'll produce the plants. It's their plants. It's their agriculture.
Yeah, but I think it all gets back to, again, listening to other people's perspectives to try to figure out why they're seeing something differently than the way you're seeing it, right? And then seeing, is there a way to bridge this? Is there, or do we have to go down to find some kind of common denominator? But in the idea of thinking we're going to educate them out of their positions, that just doesn't work.
What I hear from you all is that there's a little bit of a need for cultural humility to acknowledge that we don't have all the answers, and we need to do our due diligence to work with individuals who are affected so that we can have better answers, maybe not perfect, but better answers. Thank you all for that really interesting dialogue. There's another question here from an audience member. What are some interesting areas in AI and healthcare research that might go unnoticed, but will ultimately prove essential? Again, anyone can answer this.
Take a shot at answering. Something I didn't mention earlier that might be useful and could be articulated briefly is what goes by the name of citizen science. We have a lot of compatriots who are really quite engaged by this. And you don't need to be a cell biologist, with all due respect to my colleagues, in order to contribute. You don't need to be a physicist to contribute to learning about astronomy. But when we do this in health and when citizen scientists actually start fooling around with things and learning things, I think there may be great opportunities.
I would like to see AI, and I don't know. So, Dr. McGreevy, tell me if I'm off on this, McGarvey. The idea currently in the world in healthcare is that there's a great need for more education, but the education, since it needs to meet certain standards for accreditation, has to be somewhat homogeneous. And yet there are places around the world where you don't, again, as Dr. Goodman said, you don't have to be a cell biologist, right? You don't need to be an MD or a DO. You could just be a neighborhood healthcare provider with whatever specialized information you might need for your particular community. And the additional benefit of that would be, since you didn't spend all the money to get the SOTA accredited status, then you're not tempted necessarily to leave and go somewhere else where you're going to make more money, right? To leave your community. So how can we do a better job? And again, it's a tough problem, but it's a big problem, and it may be a problem that AI could very much help us with in terms of tailoring the education to the needs of a particular community. And by that, I mean very small, individual community all around the world with all the diversity.
I have an answer for you.
Could you write a grant?
I don't have experience actually in community healthcare, so I defer to other people here.
Peter, we're just making this up, you understand?
Yeah.
It was a speculative question about the future, and it's engaging. What is it? What in the future will we find that's going on today that will be effective? And the answer is it's not bad to be thinking about these things. My thought was a sentiment for ordinary people contributing to their communities and to their own community's health, which is why some of the research on social determinants, no matter what you're allowed to call it this week, is so vitally important.
I agree. Guess we just need everybody could help with. I mean, if they're worried about health, maybe you can donate your own data and stuff. I mean, there are places that will take your genome sequencing and medical data. There are people. I would have no problem doing that and just giving it all away. I asked all of us if they wanted it once, but they said they didn't need any older white men anymore. So that's not what they were looking for.
We're a little overrepresented in that database, yeah.
Which, by the way, is a point worth making to people who are concerned about some of these issues. When we say if you take a Howard University hospital data set and suddenly some field trip from, I don't know, Beverly Hills shows up, right? The patients from Beverly Hills are going to be compared to the data set that was generated by the Howard University Hospital. It's going to be biased in the sense that it doesn't represent the people who are seeking the care. That doesn't mean that everybody who's got a biased database is a racist. It means that our culture is divided in ways that have the constant effect of putting a thumb on the scale, independently of any desire to make the numbers look different. We don't live in a society that's homogenous in the way that we all might prefer. And that produces these problems. It has nothing to do with being woke. It has nothing to do with DEI. It has to do with good science and the creation of accurate models and databases. It's about good data collection, not about anything else. And I think ordinary people probably understand that.
At least I would hope so. Okay, we've got another question for you here that I've paraphrased a little bit. With tools like ChatGPT and DeepSeek, it is relatively easy to identify hallucinations and verify the authenticity of the information generated. However, there's a concern about hallucinations in models where the inaccuracies aren't as obvious, such as erroneous correlations that seem plausible but are fundamentally flawed. Can the panel speak to this broader issue? And do you anticipate an increase in retractions of published correlations due to these AI-generated hallucinations that we can't immediately detect?
Well, trouble is all those really big models are controlled by big companies. I think they could devise some tests for hallucinations. I mean, it's basically testing. I mean, when we build other machines, we test them to make sure they're reliable. Auto companies drive them for 100,000 miles to see what breaks, or they used to, and things. Could somehow enforce something more of that. I don't know the right way to do it, but to look for them or compare them. But right now they're making new ones so fast.
But it raises the great issue that I think we could do more with in terms of this whole bias thing. If you go back, I think it was 2005, John Unitas published a paper which the title was "Why Are Most Clinical Research Articles Wrong?" And he didn't say some, a few, he said most. And if you go back and look at the comments to the article, I wouldn't recommend reading the article unless you're having trouble sleeping at night. But the comments were fascinating because the comments were not, "You got it wrong." The comments were, "Why are you putting this out into the public? Because it's going to harm our funding, our research funding." So bias has always been there. Bias is fundamental to anything human. And it's in peer-reviewed scientific publication, has been proven that is not an issue anymore. The issue is, what do we do with it? How are we addressing it? And I think the struggles that we're looking at with AI bias are, in a sense, parallel to the ones we're looking at human bias. So how do we get the biases out, period, is the question, I think. Well, I'm not going to load this all on AI. I think we've got enough human bias to deal with too.
You may remember the first prognostic scoring systems in hospitals, the unhappily named Apache systems.
Yeah.
Sold as being unbiased because we know you humans are going to are going to be biased. But in some sense, Dr. Tobo, you've asked, this is an important epistemological question, how we know what we know. And you look at the history of biomedical science and how often in the normal, even people with good intent, adequate funding, no bias if you can imagine it, they're going to get it wrong until they get it right. Most of the scientific corpus has stuff in it for the last couple thousand years that's just mistaken. Well, because anyone wanted to deceive anybody, just learning how the world works is a great challenge. And what we saw from Dr. Fitzgerald's presentation about genetics, every 20 minutes we're learning something exciting and interesting about this. It means we can't have gotten it right until as of yesterday, right? And that it's been called, it's self-correction. It's with adequate transparency and adequate commitment to research integrity, we will eventually get it right. Which is why I said earlier, if you're going to get sick today, not 70 years ago, right? if you have that opportunity to choose. In other words, what our colleagues in nursing and medicine and so forth have today is far more than they did when most of us were children. And so the granularity may not, or the speed with which this is happening may frustrate us. But the goal of identifying truths, I think, is still, as opposed to simply solving problems, I think is still an important and worthy goal.
And science does keep making it tougher. I mean, right now, there's stuff that's published years ago. You couldn't publish because the editors are going to say, you need more data, you need to replicate it at 2 more health centers and things, which is hard to do. When I was a molecular biologist, they say, well, you can't do 1 gene. And then it had to be the whole genome. It was a whole virus, and then it was a whole genome, and people got tenure for doing 3 genes.
Turn that into a shout out to our colleagues in government who work for the National Institutes of Health and who discovered that when we can't replicate or reproduce or corroborate or confirm other experiments, that's a problem. It's an interesting conceptual problem. It's easily explained if you're in Denver and I'm in Miami, and so somebody's at sea level and somebody's a mile high. That might explain it. But otherwise, what are we doing in terms of rigor and reproducibility? That's just being careful stewards of the resources we're given and the data with which we've been entrusted. We need to do a better job with that. In an environment where, how should we say this? Not to criticize any universities or anything, but we have created a culture that basically says, publish more stuff. Actually, worse than that. We've created a culture that says, get your name on a paper. On a daily basis, the most common source of disputes that I encounter in laboratories is, why is his name on the paper ahead of mine, and who put her on it all? As if you get to put your name on a paper. That scientists have allowed it's a thoroughgoing, in your face, under your nose bit of corruption having to do with the published record, because we commodified it. You're not going to get grants and you're not going to get promoted. And so therefore we have people whose names are on 1,000 papers, but wouldn't understand a word of half the papers their names are on. That's not good science. That's not good process. That's not a good use of public resources.
As I listen to this really fascinating conversation, I can't help but think about a really interesting paper or publication from, and I'd like to share my screen because I thought it was so fascinating that I had to try and visually conceptualize it. So a recent article from MIT Sloan Management Review titled "Philosophy Eats AI" argues that philosophy shapes AI more than we realize, and that the biggest challenges in AI are actually not technical, but rather philosophical questions. And I'm sort of detecting that in some of the responses that I've been hearing in the last few minutes. So these are questions around ethics and accountability and human values. So given your expertise, I think I know the answer, but I want to ask anyway. Do you agree with this framing? And if so, what steps would you recommend that organizations take to proactively foster that philosophical rigor in AI development, rather than perhaps what we're seeing, which is a reliance on reactive solutions to address its unintended consequences after the fact?
Anybody tried training in a large language model with philosophical or ethical documents? I'm serious. Somebody could do some experiments.
That's how people try to develop ethics decision support using AI and chatbots. Well, if you ask me, the philosopher, the answer is absolutely right. In part, though, because there's several branches of philosophy, recall. One of them is logic, right? These computer programs, at the end of the day, are logic machines. Remember, anytime I don't know who's in the audience. Remember what an algorithm is. An algorithm is, if this, then that. That's an algorithm. If it rains, then I'll get wet. Now, the algorithms get interesting where if it rains and I've got a leaky umbrella, then I'll get less wet. And you can make them more or less complicated. But an algorithm is, if you see this complicated in various ways, then you can make certain valid inferences from it. Another branch of philosophy is moral philosophy or ethics. What makes something right or good? A third branch is epistemology, or the study of knowledge. Under what circumstances do we have adequate evidence to justify a belief? First, when I get to teach students, the first thing I say is, why do you believe what you believe and not something else? And then the corollary is, under what circumstances ought you to change your belief? Right? I'm looking out now, and evidence I have is that the Earth is flat, just based on my observation right now. And so we need to be able to find better ways of analyzing the data we have, starting with sense impressions, in order to do that. So it's not that philosophy eats AI. I find that to be hostile and aggressive. It was something perhaps more congenial would be nice. Namely, that the value some people believe, and I reckon Peter and Kevin do, is that what we do philosophy is we celebrate critical thinking. And we can do that in theology, we can do that in cell biology, we can do that in moral philosophy, we can do that in computer science.
And it is funny, philosophy eats AI, right? It's a bit much in that regard, because it would just be us eating ourselves. I mean, it's human endeavors, both of them, right? And so, of course, our larger frameworks are going to be those that are going to be housing the smaller frameworks, and AI is the smaller framework. I think the interesting tension, getting back to cultural and societal challenges, right? The interesting tension is what happens when AI breaks out of the human context in which we house it, right? So of course the machines take over and they wipe us out, and they go merrily on and doing whatever it is they're doing until, of course, the power runs out. So that's always a thing I never notice in any of those movies. The power never runs out. It's like, wow, this is great. How did they figure that one out? So of course, this is all human endeavor. So of course the philosophy is the bigger, issue. But the question is, are we aware enough? Are we integrating enough what we're learning from AI into our larger understanding of ourselves and our goals and how we want to get there? Because I think we are learning very important lessons if we take the time to learn them and to reflect on those. But as we've heard, things are moving very fast. I don't have time to reflect. I don't have time to integrate. I don't have time because I got to get my name on all those articles so I can get a grant, so I can get more articles, so I get more. So, okay, where are we going? So I think that's where we got to use this opportunity to ask ourselves, step back, reflect, and say, where is it we say we want to go? And is this the way to get there?
By the way, you raised an important issue. The amount of energy and the amount of water that is used to generate all of this stuff is extraordinary. That's why I don't want to mention any trade names here, but by a very large computer company that makes your operating system, your Outlook, and your Word, now has bought itself a nuclear reactor.
Yeah.
And Microsoft, in the interest of quantum computing, boy, if you think it's interesting now, wait till the quantum computers kick in. Apparently, Microsoft side, Peter, you may know more about this than I do. They've actually developed a new form of matter that apparently is useful in future quantum computers. It's not solid, it's not liquid, it's not gel, it's not that sort of thing, or gas or vapor. You will understand why some people say, "Hang on a second. If these corporations can run nuclear reactors, discover new states of matter, Google patented work in protein folding, very important problem in biology, that was solved by a corporation." You can imagine why some people might be actually deluded into believing that all we need are companies. What do we need all those universities for? With all their cranky faculty, with their publications, and all their woke committees. We could have businesses do it all.
Other engineers came out of some university.
You could imagine. I'm trying to not go off message, but the university is the foundation of Western civilization and Eastern civilization, for that matter. And is it flawed? Yes. Do we make mistakes all the time? Do we have incompetent colleagues? Of course. But don't damage them, because they're the goal, the jewel rather of civilization, and the goal as well. It's about learning, it's about rigor, it's about science, and we would not want to delegate that to large computer corporations, engineering firms, or political parties.
As a fellow academic, thank you for saying that. One question that I have for you, Dr. Goodwin, actually, it's from an alumna at University of Miami. They would like to know if you've been to campus recently. That's just a fun little sidebar question that was submitted.
Have I been to campus?
Oh, well, I guess it could have been directed at me, but I imagine it was directed at you. Just a fun little question.
Yes.
Yeah,
Once in a while, I actually turn up for work. It's amazing.
Figured the answer was yes. Well, so a question that this person also submitted is, what recommendations, and this is open for anybody, what recommendations do you have for research institutions, particularly HBCUs, and that acronym means historically Black colleges or universities, when proposing research topics that focus on identity and incorporate DEI considerations, diversity, equity, and inclusion, that is. Should there be any specific concerns to keep in mind, or should such research topics proceed without hesitation? This is it.
You do not see the elephant and the gorilla in the room. That's against the law now, you understand.
I just figured I would let the panel speak to this. And
well, one thing you can do is ask yourself what aspect of identity you are identifying, because there's many different types of identity. We each have our own genetic identity, right? And that's just undeniable. And even if you have an identical twin or triplets or whatever, they're still going to be different on a molecular level. So I don't see there's any difficulty looking at that identity. I think we're talking about different sort of conceptualizations of identity or verbalizations of identity that have become so politically contentious, right? So have the project look at why they become politically contentious. Now you're just doing a meta study.
Great.
If I might, just a shout out to one of my first academic jobs wasn't a fancy place like Howard, but it was at Bethune-Cookman College in Florida. Mary Bethune created a college about 100 years ago for Black kids who'd never be able to go to any other university. There's a wonderful statue of her in Washington, by the way. So y'all in Washington, do a field trip to the statue for Mary Bethune. One could say, don't we wish we lived in a country where we didn't need to have such institutions? But we do. To the extent that you agree with anyone who says that learning how to perfect our democracy, learn how to do better science, learn how to hew to bold-faced moral obligations requires looking at that sort of thing, then find a way to do it. You're not going to get a grant for it for a while, at least. But we don't do this. We don't do the research because we want to upset people. We do the research because they're profound empirical questions about how social determinants and histories of discrimination, not to mention, thank you very much, Kevin, slavery, have shaped our country. So it becomes irresponsible not to look at those issues, at why diversity matters. It's an empirical question, not as a matter of wokeness. It's a moral obligation. I wish more people saw that, because it seems so obvious to me.
Well said, Dr. Goodman. Thank you so much. Well, I have to admit, listening to all of our speakers has been quite an enriching experience for me. I know I've learned a lot, and I hope that our audience feels the same. As much as I'd love for this conversation to continue, and I could sit and listen to you all day, we do need to wrap up. Before we close, I'd like to extend my deepest gratitude to our panelists, Dr. Goodman, Dr. Fitzgerald, and Dr. McGarvey, for their outstanding contributions to our dialogue today. Your insights have really illuminated key challenges and opportunities in ethics, in public health, in medical innovation, and in data science. To our audience, thank you so much for your engagement, your thoughtful questions, as well as your presence today. Your participation is what made this discussion even more meaningful. Finally, I'd like to thank the Conference Planning Committee for their behind-the-scenes effort in organizing this symposium, as Dr. Marjorie Gondry-Lewis already beautifully stated at the beginning. Everyone's dedication made today's event possible. Before you leave, please do take a moment to complete our event evaluation using the QR code or link that is displayed on your screen. Your feedback helps us to improve future events. Thank you all so much for joining us today. We look forward to continuing these important conversations. Take care and see you next time.
Thank you.
Thanks so much. Get better, Asia.
Yeah, and thank you, everybody,
Thank you, Dr. Hurtado.
so much for the panelists. We really, really appreciate it. It was so good and challenging and great discussion. Appreciate that. Thank you.